Just start in 3 minutes. I'm just checking with other. Nishit sir, good evening.
Good evening. How are you?
We are good, sir. How are you?
I'm good. Still in good health so far.
That's really nice. Anil sir, good evening. Sir, you're on mute. You need to unmute, sir.
Can you hear me now?
Yeah, absolutely, sir. We can hear you.
I couldn't get you on my bigger phone, but I'll try on that. So, सब ठीक है?
हाँ, सब ठीक है, sir. मैं एक बार Rishabh, you have not started live streaming, na? You have started it. Started.
Good evening, Dr. De Cruz. Good evening, all our.
Good evening. आपकी बैकग्राउंड बहुत पिक्चरस लग रही है.
Thank you, sir. Thank you very much.
Lovely. I'll turn the phone in such a way. Maybe no, I think this is better.
Very nice. It looks nice. Yes.
Meena ma'am, good evening.
Good evening. Good evening,
Pavan sir, good
Dr.
evening.
Pooja. Good evening, Dr. Pavan. Good evening, Rishabh. And good evening, all our dear friends here, and all our dignitaries, all our participants, and everybody else.
Good evening, one and all.
Thank you, Dr. Pooja. Nice to have you here.
Just sharing my screen, for Anil sir. Anil sir, this is how the screen would look like.
Okay, lovely. Oh, that looks very impressive. I should take a photo, or you give me a photo of this with my name on it. And what do I?
Yes, sir. Once you press inaugurate, once you press this button, I'm going to give you remote control now just for a testing.
Okay, lovely. I'll do it. Perfect.
I can't see your name.
Keep it little open. They must see me. Yeah, bus.
Okay, मुझे दिखाई नहीं दे रहा. Somehow I'm not able to give you, maybe because of the phone.
नहीं ठीक है. You just tell me, Anil, please inaugurate Dr. De Cruz. मैं ऐसा दबाऊंगा, आप दबा दो वहां से.
हाँ ठीक है सर. जब आप इनॉग्रेट करेंगे ना तो वो आपका नाम भी आ जाएगा और फूल बरसेंगे और इनॉग्रेशन हो जाएगा.
बढ़िया बढ़िया. ठीक है. और मुझे एक फोटो भेजना बाद में.
Sure sir. Sure, बिल्कुल.
So Shruti, whenever you have De Cruz, sir, you can be relaxed, because he will be always very flexible. Good evening, sir.
Absolutely. I think it's 3:30. We can start. Pavan sir, we can start. I don't see 8 minutes. I'm not. I'll just check
yes,
with Harit sir.
Yeah, Shruti, please go ahead. It is just 3:30. Please start.
Yeah. Or so you'll call Rishabh. Can you please call Harit sir also?
Harit sir is in the hospital right now. He just gave a message that he's trying to
join, sir. If sir can join for 10 minutes.
He may, if he's able to join. Actually, he's in an emergency. He has just had to reach the hospital urgently. So, in case he's not joining, I'll give his message.
Sure. Okay, sir. Then
Please start.
We'll start then. I'm sharing my screen. A very warm good evening to all the august audience and our guests who are here with us today. It's a beautiful Sunday and also marks the Oral Cancer Awareness Month, where ICanCaRe, along with the Sterling Cancer Hospital Foundation for Head and Neck Oncology, is organizing the Oral Cancer E-Conclave for the entire month. We are going to have 4 Sundays, which are full of wonderful scientific sessions for the audience and for with great academic content, as well as great practical learning from prolific oncosurgeons who are here with us today on this event and will address us, and from whom we will have a wonderful opportunity to learn a lot of things. I thank all the partnering organizations and their respective representatives who are here with us today, who have been tirelessly working for the past fortnight to make this event really grand and successful. I'm sure that today there will be a lot of new things, lot of new teachings, lot of new experiences coming together on this forum, on this program. I'm very pleased now to invite Dr. Pooja Nandwani Patel to invite all our esteemed guests and dignitaries for the evening on the e-dais.
Thank you, Shruti. It's my privilege to have these all esteemed dignitaries joining on this web platform. And it is always a delight to invite Anil Dikro, sir. And he is the president of Union International for Cancer Control, and he is the director of Apollo Cancer Hospital. Welcome, sir. Again, a very privilege to invite Professor Dr. Himanshu Pandya. He is the Vice Chancellor at the Gujarat University, Ahmedabad. The convener and the person who is behind this conference mainly, Dr. Pawan Gupta. He is the director, Hedonic Max Institute of Cancer Care, and the Chief Medical Advisor, ICanCaRe, and also the National Convener Certified Tobacco Cessation Specialist Courses. My pleasure to invite Dr. Harit Chaturvedi, who is the chairman at the Max Institute of Cancer Care, New Delhi. Dr. Alok Thakkar, a warm welcome, who is the president of Foundation of Hedonic Oncology and also the head of the department at ENT AIMS. A privilege to invite my boss, Dr. Somesh Chandra, director at the Sterling Cancer Hospital, Ahmedabad. Dr. Reena Kumar, who is the academic director, ICanCaRe National Director, Certified Tobacco Cessation Courses. A privilege to invite Dr. Vikram Kekatpure, who is the honorary secretary of FHNO and also the director at ICanCaRe Cancer Hospitals. A warm welcome to Dr. Meenu Walia, who is the senior director, Clinical Care Center, Max Institute of Cancer Care. And of course, somebody from my hometown, Professor Dr. Rakesh Rawal, who is there at the Department of Life Sciences, director of CUSEC, coordinator of the Gujarat University Certified Tobacco Cessation Courses. So a warm welcome to all these esteemed dignitaries on this web platform. And I take this privilege, and I am very sure that this program is going to be a wonderful program and learning program for all of us. Over to you, Shruti, again.
Thank you so much, ma'am. And let me introduce Pooja, ma'am, to all our audiences here. She's senior consultant and head from the radiation department at Sterling Cancer Hospitals and a very prolific oncosurgeon herself. With this now, we move ahead towards our inauguration session, and I'll request our chief patron for the evening, Dr. Anil sir, to please press the inaugurate button, and then we will have the digital inauguration of our function.
Thank you, Shruti, for the honor. And here I am hitting on the button.
A big round of applause, everyone, on your cameras. Thank you so much, sir. I think that was really wonderful. And now we begin this session, actually. So we will have a short lighting of lamp. That was the e-lighting, the digital lamp lighting from all the dignitaries on the e-dais. And now with this, I invite Dr. Harit K. Chaturvedi, who is chairman at Max Institute of Cancer Care India and currently the president-elect of Indian Association of Surgical Oncology, to kindly give his inaugural address. Sir is a very prolific oncosurgeon once again, and he has more than 30 years of experience in the current field. He also leads oncology team at Max Healthcare, which has 80 centers across Delhi NCR region. His focus is on providing quality care through various initiatives like virtual tumor boards and driving subspecialty built up across the Max centers. He drives the ambitious oncology vision at Max Healthcare with a strong focus on people, processes, and systems, and has key role in clinical quality processes, clinician recruitment, and long-term vision and strategy for the group. It is a privilege that we have sir's presence, and I'll invite him to have his address now.
Yeah, thanks, Shruti. Actually, Dr. Harit, I will just say a few words on behalf of Dr. Harith, because Dr. Harith is right now in the hospital for some emergency. So Dr. Harith has sent his best wishes for the program, and he has wished this 4 weeks program to be a enlightening one for the participants. And we have approximately 1146 people who have joined, who have registered for the program, and across 4 weeks. So it is this oral cancer, which is basically the most important cancer in India, which is which needs to be taken care. So this program was made along with Dr. Harith, who is my boss at Max Hospital. So he sends his best wishes for the program. Thank you so much. Shruti, please continue.
Yeah, thank you so much, sir. And now I'll invite Pooja ma'am once again.
So, as we say, the boss is always right. But I think I'm very blessed to have such a boss that who always takes along with his companion. And it is my privilege to invite and welcome Dr. Somesh Chandra sir, who is the director at the Sterling Cancer Hospital. He has served at the prestigious Gujarat Cancer Research Institute as a professor over 7 years as faculty, and has been also the director of oncology at Kailash Cancer and Research Institute, Goraj, Vadodara. He has innumerous publications to his credit and has served many organizations at very prestigious posts. Has a decade of experience with central lymph node technique and mammoplastic techniques, breast cancer. Has a vast experience in various oncology cases, also in the robotic surgery, scarless head and neck surgery. I think his experience and of course his contribution to the oncology field will make a remark today when we have here with us. Also, he's waiting for his very important talk on the second Sunday. So my privilege to welcome you, sir. Dr. Somesh, sir, over to you.
Thank you, Pooja, for that unbelievable introduction. And a very warm welcome to all the dignitaries, Dr. Nikruz, Dr. Alok, Dr. Pawan, yourself, Dr. Raval, and all the people who have joined us on this program. Actually, these introductory statements were to be made by Dr. Pawan Gupta. So I speak on his behalf. He called this entire program Intrigues of Oral Cancer. The first thing which was intriguing to me was that he chose not to label it as head and neck cancer. So that's the first message which he has tried to give to all of us, that oral cancers are quite heterogeneous, and they certainly cannot be clubbed and taken as the same as all other head and neck cancers. And over the period of coming 4 weeks, we will unravel what are the intriguing issues, and we have the best experts right from the president of the UICC and the president of FHNO to guide us through these 4 weeks of interesting sessions. Thank you.
Thank you so much, sir, for the address. And now we'll invite Vikram, sir, on the dais. So Vikram Kekatpuri, sir.
Good afternoon. So it's my privilege to introduce our president, Professor Alok Thakkar, who is the current president of Foundation for Head and Neck Oncology. Professor Alok is also head of ENT and Head and Neck Services at All India Institute of Medical Sciences. He has been a founder member and a very passionate member of Foundation and leading the field for improving the oral oncology and the head and neck oncology care in the country. Besides head and neck oncology, he has special interest in skull-based conservative laryngeal surgery, transoral surgery, robotics. So over to you, Alok sir, for your address.
Thank you, Vikram. So let me first say that it's great to see the enthusiasm and the energy of this group. So it's really nice. And of course, my greetings to Dr. Nikruz, Dr. Somesh Chandra, Dr. Pawan, Dr. Pooja, and frankly, everybody else who's been part of this enthusiastic organization. So we at the FHNO are obviously happy, more than happy, and obviously privileged to be part and parcel of this collaboration that we have just gone through. It's been I would say, a whirlwind round of organizing in the way that we have gone around organizing this 4 weeks of academics. And we have managed to put through an excellent program with an excellent faculty, which to my mind is not quite inspired and inspired by the priorities and the questions of the West, but by the priorities and questions that we face in our world. I really look forward to it. I am sure it's going to be an interesting 4 weeks. And of course, we look forward to further collaboration. So thank you all.
Thank you so much, sir, for the address. And now I am extremely happy to invite our dearest academic director from the ICanCaRe Academy, Dr. Reena R. Kumar. She is an extraordinary person and very passionate about the cause. She's also working at the National.
Thank you, Shruti. Thank you so much. I think we'll just skip all that and we'll just go on.
Sure, ma'am. Sure.
Thank you, Shruti, for this invite. And on behalf of ICanCaRe Team, ICanCaRe, the President UICC, President FHNO, Director Sterling Hospital, and all our partners, we are so delighted to have all of you here today and make this into a program which is unique. In this month of April, a lot happens, yes, because oral squamous cell carcinoma is one of the most prevalent cancers worldwide. And it is considered a very aggressive tumor, and majority of our patients display so many local, regionally advanced disease. And as oral cancer has multiple etiologies and is primarily linked to health-related behaviors and incidence of oral cancer, can primarily be effectively controlled, I would say, with health education and preventive healthcare in the public. So when I am speaking here on the dais of ICanCaRe and representing ICanCaRe, I would say at the heart of ICanCaRe protocol lies education, advocacy, and empowerment of all sectors of society. The spectrum includes healthcare professionals, institutions, youth, teachers, social responsible bodies, corporates, and public at large. Because through our numerous courses to address the skill and knowledge gap through digital empowerment solutions and public awareness campaigns, that is how we at ICanCaRe are focused on making sure that this particular menace in this month is what is reached out and always from our platform. Thank you so much for being here today with us, and we look forward to an evening of collaborative learning towards best practices and preventive and therapeutic clinical outcomes for our patients. Thank you, Shruti.
Thank you so much, ma'am, for the great words. And now I'll again invite Pooja, ma'am. Okay, Pooja ma'am has probably got dropped off because of network issues. So it's an honor to now invite Professor Dr. Himanshu Pandya, who is Vice Chancellor from Gujarat University. He is also into an emergency visit and he's not here with us today, but we have on his behalf Dr. Rakesh Rawal, who is the professor from the Life Sciences Department and also the course coordinator for the tobacco cessation courses between ICanCaRe and Gujarat University. So now I invite sir to have Himanshu sir's message on his behalf. Rakesh sir, over to you.
Yeah, thank you, Shruti. Good afternoon, everyone. It's my privilege and pleasure to read out the message of our Honorable Vice Chancellor, Professor Dr. Himanshu Pandya. He says, greetings from Gujarat University to all dignitaries and cancer experts present here. I wish to extend my sincere gratitude to the organizing team of the Econclave for inviting me. I really wish to interact with you all online, but due to some unavoidable reasons, I couldn't make it possible this time. I came to know that April is designated as the Oral Cancer Awareness Month with a purpose to make all-out effort to reach out to the public, physicians, surgeons, and dental practitioners so that they incorporate the knowledge in their practice, which will make a huge difference in the incidence as well as outcome of this dreaded disease. There is a huge gap and more of the primary health care specialists need to be trained. Gujarat University looks forward to introduce more such courses and collaborative research on early diagnostic markers, risk stratifiers, and prognostic indicators, which will have impact in the lives of the common people and influence the economic growth through Healthy India. I congratulate ICanCaRe Foundation of Hedonic Oncology, Sterling Cancer Hospital, Max Healthcare for organizing the Econclave on oral cancer with the theme Intrigues of Oral Cancers. And I'm sure it would have a huge impact in the days to come. I wish all the best for the success of the conclave. Namaste.
Thank you so much. So that was a wonderful message from our dear Vice Chancellor. And now this is the moment for which we have been waiting, the address of our Chief Patron. And now I'll invite Reena ma'am to first introduce Anil sir to all of our audience.
Thank you, Shruti. It is such an honor, Dr. Anil sir. This is like, for me, it's the evening is made because Dr. De Cruz, the president of UICC for the term 2022 and director oncology, Apollo Hospitals, ex-director at Tata Memorial Hospital, Mumbai, a researcher, administrator, and crusader beyond par in the field of cancer control with special interest in tobacco advocacy, cost-effective treatment, and health economics. Dr. De Cruz has served at the UICC Board of Directors for 2 terms, adding value in membership, governance, and finance committees. He was also Program Committee Co-Chair for 2016 World Cancer Congress at Paris and member of the World Cancer Congress Organizing Committee for the Melbourne Conference in 2014. Dr. De Cruz served as editor of Manual of Clinical Oncology, a UICC publication, and of course he has a pivotal contributions, over 200 peer-reviewed publications and over 300 lectures, 50 named orations, plenary lectures, and keynote presentations around the globe. Dr. De Cruz, sir, thank you so much for being with us, and we are so honored. We are waiting to hear your pearls of advice and your address, sir.
Thank you very much. Humbling words. And thank you to the organizers for having me on such an important program. For us today, in our Christian calendar, it's a big day. It's Easter. It's one of our biggest festivals. But when Pawan and Shruti invited me, I said I must come for this program because to me, it's something that needs to be done. It's something dear to my heart. But most importantly, it's the need of what we need within our country today. Oral cancers, and this has been said by various speakers, is probably one of the highest incidence cancers in our country. I've been treating it for more than 30 years. It's a paradox because this cancer can be detected very, very early. Unfortunately, the majority of people in our country come at advanced stage. People get treated at various places and not correctly. And I think Pawan and the organizers have really put a wonderful 4-week program together where they cover each aspect of oral cancer. It goes from early detection to early cancers to locally advanced and to rehabilitations. And this is a cancer, as has been said by previous speakers, that has a poor outcome, has severe functional and cosmetic morbidity affecting the quality of life of our patients. As I treat patients with oral cancer, I believe that 50% of the work that I do is redo cancers that have not been treated correctly at the first bite by other clinicians who are not initiated in the field. And again, congratulations to the organizers putting together a great program, but more importantly, getting together the who's who in the field from within the country. People who treat this cancer with finesse day in and day out, and they'll be able to share their experiences and probably get many a youngster who tunes in for these programs to treat patients correctly. But I think most importantly, while we treat our patients, we must remember that oral cancer is a preventable cancer. And great kudos again to ICanCaRe group, the entire leadership for putting together this crusade against tobacco. As you look at statistics from within our country, over 40% of our countrymen, sometime or the other in their life, would be addicted to tobacco. That's a huge number. And while you lead literature in the West, where there's a lot of focus on smoked tobacco, about 2/3 of all tobacco consumption in our country is chewed. And I think institutions, organizations such as ICanCaRe can take this message of tobacco out, and hopefully in the years to come, we'll have less consumption of tobacco, prevention of a large number of cases, helping with early detection and right treatment for our patients. So while today I'm chief patron, and I get worried when they call me chief patron, it looks like my time is up treating patients. When they put you into the patron bracket, means that, sir, your time is up. But jokes apart, while I'm here today as president of the UICC, I think my heart is in this entire 4 weeks of program, more as a clinician who treats these cancers and really feels the need that these cancers need to be prevented, early detected, and treated appropriately. So thanks once again for having me today to inaugurate this lovely session, and I'll be following all 4 weeks of the proceedings. Good luck to the organizations, speakers. We'll expect the best from you, and to all delegates to listen to us. Take home as much as you can, because you're talking to the who's who in the field from within the country. Thank you once again for having me here this afternoon.
Thank you so much, sir. Ladies and gentlemen, please a big round of applause for Anil De Cruz, sir. That was a wonderful thought which has been given. And I'm very happy, and we are extremely honored to have your gracious presence, and we'll have you throughout the 4 sessions. With this, now I invite Dr. Vikram Kekatpure, who is Secretary from Foundation of Head and Neck Oncology, to give the vote of thanks. Sir has been the secretary and has been tirelessly working to make this event successful, and also to ensure that cancers are prevented and it's being handled very well. He's a senior consultant and director of Head and Neck Oncology and director of Tissue Repository Program at ICanCaRe Cancer Hospital, Bangalore. With this, I invite sir on the forum on the e-dais to share his words.
Thank you. Good afternoon, everybody. I would really like to thank, on behalf of the organizing committee, each one of you for joining this campaign to create awareness regarding oral cancer from prevention to management of advanced disease, jointly organized by Max Healthcare, Sterling Cancer Hospital, ICanCaRe, and Foundation for Head and Neck Oncology. Real thanks to Dr. De Cruz joining us today on a very important day, but that just goes on to show his commitment to the field of oral cancer. Patron in Chief for inaugurating the meeting and a very meaningful address with the deep insights with years of experience. It is an honor to have you, sir, as a faculty for this meeting. Dr. De Cruz is a foremost leader in the field of head and neck oncology and a mentor to many in this field. We acknowledge the support from Dr. Pandya, Vice Chancellor, and for a very pertinent message. Oncologic leadership of Dr. Harit Chaturvedi from Max Hospital, Dr. Somesh Chandra from Sterling Cancer Hospital, Alok Thakkar, President of Foundation for Head and Neck Oncology, deserve credit for unwavering support and guidance for the program. Dr. Pawan Gupta has really been instrumental in organizing this meeting and aptly supported by Dr. Pooja, Professor Walia, Professor Raval, Dr. Reena Kumar, and all the partnering organizers. Really appreciate the hard work which has gone in putting together this program. Also acknowledge our MC today, Ms. Shruti, and the entire technical team. Very grateful finally to all our faculty and most importantly, the participants. We request all of you to take this opportunity to interact and learn from faculty and also from each other's experience for ultimately prevention and improving the care for our oral cancer patient. Hope you have a great academic experience. Thank you very much.
Thank you so much, sir, for the kind words. And now with this, we move ahead to the launch of our scientific sessions. This was the inauguration ceremony, ladies and gentlemen. And now I'm very Glad to invite Dr. Meenu Walia, who is also Director of Clinical Cancer Care from Max Institute of Cancer Care. She's a renowned cancer specialist with more than 30 years of experience in treating the cancer patients and is the first DNB from Medical Oncologists of India. Currently, she spearheads the Department of Medical Oncology and Hematology at Max Institute. She has been decorated with various awards, namely the Bharat Jyoti Award, Medical Excellence by Indian Medical Association multiple times. She's a keen cancer researcher and is the principal investigator of various international clinical research trials. She's the author of a popular book among cancer patients, Tips for Happiness in the Shadow of Cancer, and is a TEDx speaker. She's extremely inspirational and passionate about her work. With this, I now invited Dr. Meenu ma'am on the forum to kindly give the opening address and launch the scientific sessions for the evening.
Thank you, Shruti. Thank you for such a warm introduction. My honor and my privilege to be a part of this team and to be a part of this forum where, as rightly said by my predecessors, the who's and who of oncology, the who's and who of this field are here. I welcome you all today to the ICanCaRe Oral Cancer, Intrigues of Oral Cancer E-Conclave. This is one of its kind E-Conclave that is going to be spread across a series of 4 online programs every Sunday in this month, in the month of April, which is observed as the Oral Cancer Awareness Month. Many before me have already talked about oral cancer. We know that it is a cancer which ranks amongst the top 3 types of cancer in our country, and it is a significant public health problem. We commonly witness the problem is not only related to this cancer alone, but many things behind it, whether it is tobacco and whatnot, and even the problems posed in early diagnosis and the problems related to the treatment in countries like us. So in our first session of the series, we will be discussing about the various challenges, which are involved in diagnosing these oral lesions, and gives me immense pleasure to welcome the who's who of oncology, all the esteemed speakers. Sessions would add great value to our existing knowledge, and the new learnings would turn out to be practice of any specific session of the E-Conclave open. And over to
I think we lost connectivity from Meenu ma'am, but we heard her address. And thank you so much, ma'am, for inaugurating the scientific sessions. And with this, we move ahead with the first session. And I'll invite Dr. Pooja again, who is the senior consultant and head at Sterling Cancer Hospital, to please start the scientific sessions for the evening.
Thank you, Shruti. So I think the program is all set. So we, without wasting much time, I would now start with the first talk. The rules of this program are very simple, that I would first of all request all the speakers to please be on time. I think it is, the first talk is by Dr. Nishit Soni. He did his master's in dental surgery from the Government Dental College, Ahmedabad in 2006. And then he has served as assistant professor at the K.M. Shah Dental College, Vadodara, Karnataka School of Dentistry, Gandhinagar, and Goenka Research Institute of Dental Sciences, Gandhinagar. After that, since 2009, he's been doing private dental practice at the Dentasculpt Dental Clinic, and he's been also associated with Tobacco Intervention Initiative Program of IDA since 2019. For this session, for his talk, I invite Dr. Prashant Shah, who will be the chairperson. He has completed, Dr. Prashant Shah has completed his graduation from Government Dental College and Hospital, Ahmedabad in 2003. Currently, he is working as a dental practitioner and owns his multiple dental clinics since 2004. He has been elected as president of IDA Vadodara branch for the year 2019-2020 and also 2020-21, and also been member of IDA since the last 15 years and been serving the association at various posts. So without much delaying, I am now forwarding it to Dr. Prashant Shah for the further thing. Just a quick request to Dr. Prashant Shah that after the talk, you have to give your concluding remarks, and we'll invite all the questions during the open house at 4:50. So over to you, Dr. Prashant Shah.
Hello.
Yes, you're audible, Prashant.
Yeah, thank you all for making me as the chairperson for this program. Actually, oral cancer is really we in very early stage. So just looking forward all the session and like concluding the program.
I think we now forwarded to Dr. Nishit Soni for his talk. Over to Dr. Nishit Soni.
Yeah, good afternoon, everybody. Shruti, can I share my screen now?
Yes, sir, you can.
Okay. So this will be a very short, I don't know whether in detail or an introduction about the oral pre-malignant lesions. Okay, so without wasting time, we'll begin with the, I have a short presentation. So we'll begin with the presentation. Can I, is it seen?
No, so we can't see it now. It's not shared yet.
Okay.
Yes, now it's visible, sir.
Yeah. Okay. So basically, my talk of today is oral lesion, benign versus pre-malignant versus malignant lesions. So I would be covering a few introductory things about the things because I have seen the rest of the lectures. They are covering clinical as well as the pathological aspect. So what I'll do is I'm beginning with some demographics. I'll cover with the potentially malignant oral lesions. Now, this is just a quick introduction about the demographics of the cancer research conducted by, and this is basically a review conducted by National Institute of Cancer Prevention and Research, published by them. And it comprises of these things, that the oral cancer is about 10% of the total cancer detected in females, and in males, it is about 16%. So it's quite a lot number. And this data is quite disturbing, I would say, because about the when we consider the oral cancer reported globally, it is 86% of the total cases are reported just in India. So being a dental surgeon, being there are so many oncosurgeons in the list I can see, this will be a big responsibility on them, on us, on any general practitioner to detect the lesion early. And as Sir said, De Cruz Sir said, that about 40% of the Indian population, that is quite alarming. The 40% of the Indian population is having the habit of tobacco, and 2/3 of them, almost 66% of them, are almost having chewed tobacco. So that is quite alarming. Now, there are different terminologies. You know, this is not a theoretical lecture, but I would like to highlight a little about the different terminologies which has been used in oral cancer since ages, like pre-malignant lesions. I would not, of course, I'm not going to go in detail about the definitions, but the lesions are the localized portion on the oral mucosa condition or generalized state. And over a period of time, the research which has been conducted about defining these conditions has changed because of the research, the prognosis, and the treatment which has been carried out on the basis of that. So now the latest research which has been published by WHO in 2021 says that we should consider, they have got a list of lesions which were previously classified as lesions, pre-malignant lesion, pre-malignant condition, or precancerous condition. Now they are calling it potentially malignant disorders. So oral potentially malignant disorders, what they name. It is just a new name. The lesions remain same. The diseases remain same. So Now, I always wonder that why we are wasting our time in diagnosis. I'm sorry about using the harsh word, but it is a common question, whenever in practice, the people see a particular patient with some red or white patch or some sort of difficulty in opening the mouth, and they, either they ignore because they came for different condition, or they few of them are not having enough kind of knowledge to diagnose that lesion early. So I always wonder, previously when I was not associated with intervention initiative by IDA, I always wonder in the beginning when I studied that why to waste our time. So later, over a period of time, when I attended sessions, I evolved. I would like to replace the word waste with utilize. That why we have to utilize the time in diagnosis of the lesion, because it's not about that we diagnose the particular lesion in time. Like I don't operate the particular lesion, but at least I play a little part in diagnosis of certain lesions. So I would like to utilize my time in diagnosis. Why? Because whenever we are treating a patient, whenever we are performing a particular task, we are looking at some response from the target community. Like when we are treating, if the patient is in good condition, patient is having a good quality of life, then we feel happy. So that's what we do. Of course, apart from the revenue generation, that's what we do for ourselves. So basically, I would highlight a few points why we have to give a little time in diagnosis of the lesion. Like early detection means early treatment, and I think that is the main motto of organizing such kind of events. Moreover, in India, the financial cost to the patient matters a lot. Like there are so many patients out there which cannot afford the further treatment because of the finances also. Later, when they're treated, giving a proper rehab to the patient, whether we can put the particular patient in function after the treatment, that is also more important. So early detection means early treatment, and then we can even rehab, we can give a good rehab to the patient or reconstruction to the particular patient. Right. So without wasting a time, I'll just, these are just a list of the pre-malignant oral potentially malignant disorder, previously known as pre-malignant lesions, condition, precancerous conditions. So I think most of us are aware of about the terminology. In the last research that WHO has given, they have included two particular lesions in the category. The last two, the oral lichenoid lesion and oral graft versus host disease, in the category of potentially malignant disorder. So basically, this terminology, I understand from the research that these are the potentially malignant disorder that when we see in our practice, we should go for either biopsy or a long follow-up, right? If any changes are there, if any changes occur which may alarm a particular clinician, then they can go for a biopsy and further diagnosis, or they can refer to the specialist, of course, right? It is not possible for everyone to perform a biopsy in general practice or in dental practice. So they can refer to the particular specialist. Now, why these, whenever I'm looking for these slides, then I'm wondering why this lichenoid, like leukoplegia, erythroplakia, everyone is familiar of. Proliferative verrucous leukoplakia, of course, everyone is familiar of, because this is the one of the most dangerous pre-malignant lesion, previously supposed to consider terminology. Then oral submucous fibrosis, lichen planus, we are familiar. Why these lesions are added or they are considered as potentially malignant? Because, this is not only about the pathology. There are three factors that are considered to diagnose a particular lesion as an oral pre-malignant disorder. So that is, one is long follow-up. What they have done is they have compiled a number of research. They have done a long meta-analysis of the previous studies, and they have came to a conclusion that these are the lesion. Initially, they were diagnosed as benign, but now they are considered as malignant. So now put them in the category of oral pre-malignant disorder. It's the same thing whenever they have diagnosed the oral squamous cell carcinoma, the red and white patches are also found at the periphery. So they have considered this as an oral pre-malignant. So these, and they may share a morphological and cytological changes observed in epithelial malignancy. So, and the last is any of the chromosomal, genomic, or molecular alteration. So on the basis of this, they have classified this particular lesion as an oral pre-malignant lesion. Now, some of the clinical aspect which can correlate with the histopathology, I would like to identify. So basically, oral mucosa, whenever they are in different colors. So basically, oral potential malignant disorders are divided into, or clinical aspects are divided into 4 parts. Color, any different color is alarming. Why? Because normal oral mucosa is coral pink in color. So whenever it is red, that means that the epithelium underlying is unable to produce its product. So that means some morphology is there. If they are producing more, then also again, it is a white lesion. Then again, any texture abnormalities, like whether it is a white plaque, white patch, that is also alarming. If they are not producing anything on the top, that is atrophic, that is also alarming. If they are producing mixture, they are producing a speckled appearance, then also it is alarming. So these are the consideration done for the texture of the oral mucosa. So any of these things is alarming to the clinician, and they can diagnose a particular lesion as an oral pre-malignant disorder. Not only this, the location, whether it is at the one location or another location. So that is also another. And variable clinical course means follow. Now, not all the red and white patches are diagnosed as pre-malignant conditions. Now, I would consider this as a clinical pathological changes. I have prepared slide long back, but I show this in most of the lecture, that these, if you follow this, color and texture, it is the simplest form of oral pre-malignant disorder diagnosis. If any changes in the color, you can suspect, not diagnose, suspect. And any change in the texture, you can suspect. So anything which is vertically, like red papillary, white exophytic, that is called as non-homogeneous lesion, and you can consider it for biopsy. Now, not only that, these are the clinical aspect, but you have to exclude certain lesion. If you consider that previous definitions, always it is diagnosis by exclusion. So these are the lesions which are not considered for biopsy, right? White spot nevus, keratosis, candidiasis like acute pseudomembranous candidiasis or chronic hypoplastic candidiasis, lip biting or cheek biting lesions, chemical injuries like aspirin burns, leukoedema. It is just a change in the mucosa, and these normal structures, spordice spots, even oral hairy leukoplakia, HIV nicotina stomatitis due to smoking. So these are basically diagnosis by exclusion. So now we have to compile these things. There are 3 things: clinical aspect, red, white, or different texture; histopathological aspect, which can correlate with the clinically, and certain diseases which to exclude, and certain evidences from the research. Combining them, they have given us the proper criteria for diagnosis for this oral potentially malignant disorder. So with this, I think I have solved the purpose of my talk. I would like to conclude with the remark that if any of the lesions with certain features of the color and texture, changes in the color and textures are found, and if you can exclude these, the previously stated lesions, then you can say that these are the potentially malignant disorder. You can definitely go for the diagnosis and help our community or the medical fraternity to detect the particular lesion early, right? I think, Dr. Shruti, with that particular remark, I should conclude my lecture.
Thank you, Dr. Nishit Soni.
I hope I'm
over to you, Yeah, you are pretty much on time. So, Dr. Prashant Shah, a quick concluding remark from your side before we go to the next talk. Dr. Prashant, you have to unmute yourself.
Yeah, hello.
Yes, Dr. Prashant.
Audible now? Yeah. Thank you, Nishit. Actually, he was my classmate. So I'm very much happy to listen him again. Okay, now concluding about the benign and malignant tumor early diagnosis and the treatment planning. Yeah, really, all the lesions in the oral cavity definitely clinically properly diagnosed in early stage and need to be treated in very early stage. All the most probable lesions are in a good really treatment condition. So I'm just requesting all the doctors who is associated with this treatment of oral cancer and all for the early diagnosis and treatment planning to all the colleagues in the city and or the nearby friends. Thank you.
Thank you, Dr. Prashant. From all the participants, if you have any questions, you can please put your question in the chat box, and probably after all the 4 talks are over, we'll be happy to take those questions. Now, without much delay, I move on to the next talk. And for that, I invite the chairperson and Dr. Vijay Prakash Mathur, who is the professor and head, Division of Pedontics and Preventive Dentistry. He is a member in the Institute of Ethics Subcommittee for Monitoring of Adverse Events in Clinical Trials, Center of Dental Education Research. He's been also collaborating with the WHO for the oral health promotion, and is in the All India Institute of Medical Sciences, New Delhi. So he'll be chairing Dr. Riti Agarwal's talk, and it's my pleasure to have Dr. Riti Agarwal, who is a consultant histopathologist at the Max Super Specialty Hospital, Saket, New Delhi. So over to you, Dr. Riti Agarwal.
Am I audible?
Yes, you're audible. You just have to full screen your slide.
Yeah, just give me a second.
Yeah, it will take some time. No problem.
I think that's okay.
Perfect. You can
Yeah. Hi, good afternoon, all of you. I welcome you all for joining in today's meeting, and thank you, organizers. I'm Dr. Riti, and the roadmap for my today's talk will be in 2 parts. In first part, I'll be discussing, shortly about these histopathological dilemmas and clues for diagnosis in oral lesions. And in the second part, I'll be discussing a little about HPV testing. So as already the epidemiology and the data has been discussed by Dr. Nishit, so I would move directly to the dilemmas that we as histopathologists face. So first dilemma, the most common, is the pseudoepitheliomatous hyperplasia, in which we usually face whether it's malignant or not. What is pseudoepitheliomatous hyperplasia? It's actually a very fluoride reactive epithelial proliferation seen in response to a variety of conditions, which includes infection, neoplasia, inflammation, and trauma. I guess the video is not clear. And when we see it on the biopsy, it is hyperkeratotic, irregular, and infiltrative like tongues of mature squamous epithelium. The slides are stuck. Hello.
Dr. Riti, you have actually not done the screen share. You have done the reading part. So if you just do the screen share, no?
It's showing your screen sharing, sir.
If you do the full slide, then it will not get stuck. You just undo that and then do the screen slide. Full screen.
No, it's full screen only. It's full screen only, but I guess just
maybe the internet connection had some issues.
Yeah.
No. That is why, So, okay, sorry for the interruption. So, fluoride pseudoepitheliomatous hyperplasia, as I've already discussed, it's seen in response to a variety of conditions. And what we see on microscopy is hyperkeratotic, irregular, and infiltrative tongues of mature squamous epithelium. And what is important here is that there should not be any atypia, dysplasia, dyskeratosis, and atypical mitotic figures. So this is a photograph where we can see this is the hyperplastic and hyperkeratotic stratified squamous epithelium, and this irregular, these sharp edges which are coming out into the dermis. This is what pseudoepitheliomatous hyperplasia looks like. And as compared to true dysplasia, this is a mild dysplasia, then we move on to full thickness dysplasia. In dysplasia, there will be nuclear atypia, loss of polarity, dyskeratosis, and a number of mitotic activity. So this is the photograph of the dyskeratosis, where you can see these squamoid cells. showing disc keratosis. And this is a photograph of the atypical mitotic figures. This is a tripolar mitosis. So when we see these features, these help us to reach to a diagnosis that this is the true dysplastic lesion, and it's not just mild atypia or a pseudoepitheliomatous hyperplasia, which can be easily confused with the true malignancy. Okay, so these were the atypical mitosis. So the second dilemma that is very commonly discussed is verrucous hyperplasia versus verrucous carcinoma. In verrucous hyperplasia, again, the epithelium is hyperplastic, hyperkeratotic, exophytic, and with the papillary fronds. This is a photograph. This is markedly, you can see, hyperkeratotic. And this is acanthotic as the thickness has increased. And these are the papillary fronds, the church spires, what we call. And this bottom, at the bottom, these are the retics, which are broad. But still, they are not so pushing. When we see in verrucous carcinoma, they are quite pushy. But the important difference that helps us to differentiate between hyperplasia and carcinoma is the relationship of the epithelium with respect to the adjacent epithelium. This is the adjacent epithelium. Again here, these are the broad retics. With respect to the adjacent epithelium, they are still in line with the same. They are at the same level as that of the adjoining normal epithelium. And whereas in verrucous carcinoma, it's a cauliflower-like surface. You can see how hyperkeratotic, acanthotic these have become. And the retics are so blunt, club-shaped, and very broad and pushing deep into the dermis. And definitely they are far more beyond than the adjacent normal epithelium. And definitely one thing is more important is that there should not be any cytological atypia. If you start seeing cytological atypia, then you have to really look for the more tissue, because then this could be a very frank squamous cell carcinoma also. So in the biopsy, there should not be any atypia. My cursor. So this is not dysplastic. There is no nuclear dyspolarity, no loss of polarity, no nuclear hyperchromasia. There is no atypical mitotic activity. So if in this picture, I can tell you that this is a normal epithelium. As one moves to hyperplasia, definitely the hyperplasia has started. This is the exophytic fronds, but still more or less it is in line with the normal epithelium. All the fronds are at the same height and they're not so pushing and broad and bulbous. Whereas in verrucous carcinoma, these papillary fronds are going far more beyond than the adjacent normal epithelium, and deep down into the dermis also, they are very broad and pushy. These are the photographs. This is a normal epithelium, and this is the hyperkeratotic epithelium with these broad fronds, and they are far much more deeper into the tissue, into the dermis, as compared to the adjacent normal epithelium. So this is the main point that really helps us to know about verrucous hyperplasia and carcinoma. That is why it's very important in these lesions that the adjacent normal epithelium, the junction has to be there in the biopsy. Then it really helps you to identify. Otherwise, sometimes, as a pathologist, we report it as a stromoproliferative lesion, or if suppose the biopsy has been just taken from the superficial top and the biopsy is flat, then we really can't make out anything, because neither can we see the depth, nor we can see the adjacent epithelium. And when the lesion is quite, exuberant, then these are the epithelial fronds where it's, forming amalgamate, and all the sections are like this. These are, just the pictures showing you the verrucous carcinoma. Now a little about HPV testing. I won't go into the details much, as we all know that oropharyngeal carcinoma is about 40 to 60%. They are linked to HPV. And the most common site and the site for the predilection are tonsils and base of the tongue, as they are, lymphoid-rich sites. And the two types of HPV infections, low risk and high risk. Low risk is 6 and 11, and high risk is 16 and 18. And HPV 16 is the main genotype that is responsible for head and neck cancers. And when we come to HPV positive cancers, the sites of predilection being tonsil and the base of the tongue, since they are very easy for the lymphoid access, so that is why these patients present at an advanced end stage, nodal metastasis is usually seen. And when we come to the genetics, the P16 mutation happens in HPV positive, which we are able to assess through P16 IHC. That is the first surrogate marker that we like to put, because P16 is positive for HPV positive, whereas in HPV negative, P53 is there. It's a mutated and wild type. In wild type, it is heterogeneous positivity is seen, which is weak or patchy heterogeneous. And when we call P53 mutated, it can be mutated in two forms, which we see on IHC in our IHC slides. Either it could be diffusely positive, homogeneous positive, or it can be dead negative. So what is important is that dead negative should not be ignored. When it is completely negative, then also it is mutated. So that is why we prefer to write P53 wild type and mutated type rather than positive and negative, because negative in dead negative also is mutated. And for the testing, the P16 is the primarily surrogate marker that we do for by IHC. The other tests that can be done are PCR-based, DNA-ish, and latest is NGS, which helps us to characterize or identify the complete molecular structure. But I think more needs to be done in NGS, because once we identify the entire profile only, then I guess the targeted therapies and vaccines can be made out. So this is a PCR, RT-PCR can be there, and PCR-based assays actually have lower specificity, and P16 has higher sensitivity. That is why the first marker that we try to put is P16. And DNA-ish is also there. Since it is helpful to detect integrated viral DNA, it has a higher specificity and a lower sensitivity. So this is one of the algorithm that I've put, that HPV 6 markers, P16 is the first marker. And as we move downwards towards NGS, we are able to actually target the E6, E7, messenger RNAs, the microRNAs, and all the structures. So this is just to conclude, this is a slide where the P16 IHC, when it is positive, it looks like this. And HPV DNA, these are the blue, purplish dots. And in NGS, this E6, E7 messenger RNA. So it just looks more like IHC. So to conclude my talk, I would like to mention one more thing, that whenever these histological dilemmas and all these are considered, the important thing is to have a proper clinico-pathological correlation. In these biopsies, even when we are not able to see the junction, if we call up our clinicians and we ask what is the site, what is the size of the lesion, and they are really, as I can see, Dr. Rohit Nair sir is there, Dr. Akshat is there, all these clinicians of ours who are of always great help, they actually tell us what was the size of the lesion, where the incisional biopsy has been done, what were their limitations. So that also gives us a clue that yes, they are on the right place. They need to work more on that. So what we do is, in the difficult cases, we try to put cytokeratin also to see the single cell infiltration, that probably we are missing onto something. We go for deep cuts, we reorient the biopsy. Sometimes we melt our block, we reorient it, re-embed it, and go for deeper cuts so as to have a better picture. So, and that's all, I guess. That's all. Thank you so much. Thank you for the.
Thank you, Dr. Rithi. In fact, you are the one who gives us the green signal, so the role of the clinicians really actually then start. So thank you for that lucid talk. We now move on to the next talk. So may I invite Dr. Rohit Nair to be the moderator for this session.
Thank all the organizers. Am I audible? Yeah.
Yes.
I thank Pawan and the ICanCaRe team for giving me this opportunity to interact with all of you. My job is quite simple, but it is a difficult one to introduce Dr. Gauri. She's been the lead surgeon from Tata Memorial Hospital. She's a professor and surgeon, and she's in the field for last almost more than 20 years. She'll be discussing regarding the changes in the AJCC 8th edition. So lots have happened, particularly in head and neck cancers, as far as staging of oral cancers is concerned. May I request Dr. Gauri to take over and start her proceedings without wasting this time. Thank you.
Yeah, good evening, everyone, and thank you very much for having me here. Thank you, Dr. Gupta, Dr. De Cruz, and Vikram and the team from ICanCaRe for inviting me for this talk. My brief is on talking of staging and interpreting the newer aspects in AJCC 8th edition, its clinical implications. I have 15 minutes, so I must say that I have taken a small liberty here. Seeing that this is basically an oral cancer conclave, I'm going to be basically talking on the changes in the 8th edition and the implications in oral cavity cancers only. I hope that should be okay. I'm going to start by saying that staging, without doubt, is the bedrock. It is what really decides everything that we do in all kinds of treatment in every cancer. Now, the AJCC brought out the 8th edition. It published it in 2017. The 7th edition was earlier in 2010. And as the AJCC always does, it's very diligent when it brings out a new edition, changes in the TNM staging. It had 18 expert panels, 7 cores, 420 contributors from 181 institutions, 22 countries, 6 continents. So everyone was represented in this, and only then was a change made in the TNM staging. They tried to bring in other factors like comorbidities, performance status, nutrition, depression, everything into their TNM staging. And actually their vision this time in the 8th edition was to not just have TNM, but to have prognostic factors, clinical trial stratifications, risk assessment models, and change it from a population-based TNM staging to a more personalized TNM staging. So the TNM classification, the 8th edition, was published in 2017. Its implementation was started from 2018. And really there were a lot of changes in head and neck. A large bit of it was from the HPV associated cancers of the oropharynx, which was staged differently than the oropharyngeal cancers. Really, this has not made too much of a difference to us because not too many of our patients are HPV positive. The N categories were changed in the nasopharyngeal cancers. There were certain changes in the structuring of the chapters of skin cancers, salivary, mucosal malignancies of the upper aerodigestive tract. But the really interesting change that they brought about was in the T and N staging of oral cavity cancers, something of great interest to us because large part of our practice, majority of our patients, and a very common cancer in India is the oral cavity cancer. So just to revise a little bit about what was the T staging in the 7th edition. In the 7th edition, the T staging revolved around T size to more than 4 centimeters. It looked at involvement of adjacent structures, bone, skin, masticator space, etc. And in tongue cancers, it had some certain terminologies like ankyloglossia, extrinsic muscles involvement of the tongue. Now, these kind of factors like ankyloglossia were very subjective. I mean, some people thought patient had ankyloglossia, some thought didn't have. Extrinsic muscle involvement was difficult to define, not specific. People never knew how to define extrinsic muscle involvement. And this used to cause a lot of problem to us in T staging. Now, everybody realized this ankyloglossia, extrinsic muscle involvement, especially in tongue cancer, was basically a surrogate for depth of invasion. What it was showing was that depth of invasion, when it was more, you had extrinsic muscle involvement, you had ankyloglossia. And what people realized was that depth of invasion was probably a more objective way to try and define these terms rather than extrinsic muscle involvement or ankyloglossia. Now, over the last decade, what also happened was the differences between depth of invasion and thickness were better defined. People understood what was the difference. And a lot of literature came in showing depth of invasion as a very, very important prognostic factor, both for nodal metastasis and disease outcomes. So people started realizing that depth of invasion seems to be a very important factor for numerous reasons. Now, adding to that came this study, which was the Icor study, which looked at depth of invasion as an indication for postoperative radiotherapy. This was what the study was published for. We were a part of this study also. It was a retrospective analysis of around 1,500 patients, less than 4 centimeter per primordial squamous cancers. Now, what they found in this study was that for every 5 millimeter increase in the depth of invasion, there was a significant increase in the disease-specific mortality. This is when they realized, and we always knew that depth of invasion was a poor prognostic factor, but it was always related more with nodal metastasis. But they found that disease-specific mortality was also affected. And what they did then was they tried to incorporate depth of invasion in the T staging. And then this T staging with the depth of invasion was validated in an institutional data set, which was the MSKCC Princess Margaret data set. And they found there was good hazard discrimination when you included depth of invasion in the T staging. And then the depth of invasion came as one of the important factors in the 8th edition. So if you looked at the T category for oral cavity, there is no T0. The T0 is eliminated. And for every 5 millimeter increase, there is an increase in the depth of it. There is an increase in the T stage. You will also see that you do not have the ankyloglossia, the extrinsic muscles of invasion, extrinsic muscles of tongue involvement. All of that has been removed from the T4, which was very subjective and very difficult to determine. Now, when this depth of invasion came in 2018 as a part of the TNM staging, all of us were a little troubled. We all were wondering, how do you assess this depth of invasion preoperatively? And we all thought that it's in the TNM staging, it's in the clinical TNM staging, so you have to do it before we go ahead for surgery. How do we do it? The two obvious methods that we had with us was clinical examination and radiology. And all of us started putting our fingers into patients' mouths and trying to pinch tumors, palpating tumors, trying to figure out whether we can make out depth of invasion. But we have all realized in the last couple of years, 3 years, that really trying to find out depth of invasion clinically is not very easy. It's not validated. It's really difficult to evaluate for gingivobuccal cancers, alveolar cancers, hard palate cancers, and for cancers that are in the posterior part of the oral cavity. Trismus often prevents accurate examination. And this is one of the important implications of depth of invasion in the clinical TNM staging. So let's look at what happened with radiology. So the three modalities that were described for assessing depth of invasion preoperatively was ultrasound, CT scan, and MRI. Quite a few research articles trying to look at these three modalities. I'm not going through each of these research articles for want of time. I'm just going to give you a summary of radiological assessment for depth of invasion. Now, most literature looks at tumor thickness and not depth of invasion. And this is because depth of invasion actually is a pathological term. It's not a radiological term at all. So they will still report tumor thickness or whatever they think is depth of invasion. Most of the series looking at radiological preoperative assessment is small, and most is in tongue cancers. Not much of literature available for buccal cancers and gingivobuccal tumors. All three modalities, depending on which paper you read, have similar accuracy, though ultrasound seems to have a little lower accuracy compared to MRI. Some say CT scan is better. But in the whole picture, if you look at the whole picture on radiological assessment, depth of invasion probably best measured in tongue cancers with the use of an MRI. So if you look at radiological assessment, you will have to do it with either a CT scan or an MRI. Not very well validated, but that's the best option that you have available because clinical examination is pretty difficult for making out depth of invasion. Now, to add to this, this is an interesting paper which looked at do radiologists report the TNM staging in radiology reports for head and neck cancers? Excuse me. Now, this was actually conducted in 2016, and this was before this depth of invasion came. They looked at 782 respondents from the United States. Now, even before depth of invasion complicated this, and even in the United States, only 25% of radiologists actually reported the TNM staging in their radiology reports. And many of the critiques of the new TNM staging said that adding depth of invasion is going to further worsen this, and radiologists are going to rarely report the TNM staging now. And this is something that practically we also see. We do get radiologists reporting depth of invasion in tongue cancers, but in any other cancers, it's something that we don't report. Now, while we're talking so much about preoperative depth of invasion, the one question that I always ask myself is, what is really the need of preoperative depth of invasion? Do I really need to know this preoperative depth of invasion? Of course, it's there in the CTNM staging, but what is the need? Do I check it out in every patient? Now, what we know is depth of invasion predicts nodal metastasis. But in my book, elective neck dissection is now the standard of care for both early and advanced oral cancers. So I really don't need a predictor of nodal metastasis. So the role of preoperative depth of invasion, yes, you want to know the CTNM staging, but besides that, it's probably to just prognosticate. It helps counsel patients for possible adjuvant therapy. So if you have a depth of invasion that's more than a centimeter preoperatively, you know that this probably is going to be a stage 3 tumor and this patient will probably require adjuvant therapy. This patient may have higher nodal metastasis, poorer outcomes. Now, the place where the depth of invasion really has a high implication is the pathological TNM. Now, it is here that thicker tumors get upstaged to T2 and T3. And when thicker tumors get upstaged, irrespective of the T size, these patients, more patients will start receiving adjuvant radiotherapy. So depth of invasion really is very important, and the TNM staging makes a big difference in the pathological TNM staging. Now, besides depth of invasion, I just want to bring your attention to one more issue in the pathological TNM staging, and that is that superficial erosion of the bone has been removed from the TNM staging. And actually, there is no T stage for superficial bone erosion. Now, this sometimes does become a problem in the pathological T stage. This is out of experience. When you have a patient that comes to you with a histopathology report at the end of your surgery, who has a smallish tumor but does have superficial erosion, does not fit into a T3, or previously it used to be a T3 tumor, now it does not fit. There is no prognostic significance given in the pathological TNM staging for superficial bone erosion. Whether it has prognostic significance or no, we do not know. But this is one thing that does cause a problem for us sometimes when our patients come to us with superficial bone erosion in their pathology report, and the patient still becomes a T1 tumor or a T2 tumor, and we don't know whether we need to give these patients adjuvant radiotherapy or not. So depth of invasion, important in the pathological TNM staging. So since the depth of invasion has been incorporated in the TNM staging, a lot of validation of this depth of invasion and the AJCC 8th edition has happened. Numerous studies have come, 10, 15 studies have come looking at whether this depth of invasion, and that's how it should be. Literature should always check when you have a new AJCC edition that's coming. When you have so many editions, so many literature, what I like to do is look at a publication that comes from your own country. This is a wonderful publication that came from Deepak and from the Amrita group. This looked at validation of the 8th edition of the AJCC staging system in early T1, T2 oral squamous cancers. Now, they looked at 441 T1, T2 tumors in a 10-year period. They reclassified these T1, T2 tumors. These were previously classified as T1, T2 with the 7th edition. They reclassified as per the 8th edition. Now, when you reclassify, it's the same group of tumors. What happened was 50% of these tumors were upstaged. What happened is you got a new stage. Of these 441 tumors, 141 tumors went on to T3. So basically, this is the same group of patients, but now they have got upstaged to 141. And I would like to then introduce you all to a concept which is called stage migration. Now, this is one of the very, very important implications of a new edition of a TNM staging. What happens is your patients all go and do what is called a stage migration when you reevaluate these patients. Now, what this means is you have to look at the survival differences because of stage migration. If you look at the 7th edition in this particular same paper, T1 tumors had a 5-year overall survival of 78%. T2 tumors had a 5-year overall survival of 61%. Now, in the same patients, just by adding, by reclassifying them on the 8th edition, the 5-year overall survival improved to 87% for T1 tumors. It improved to 61% for T2 tumors because a large percentage of patients moved to T3 and their survival became 58%. Now, this is called stage migration. And in the new further few years, we are going to have new survival statistics for stage 1 to 4 oral cancers, and stage migration is going to be an issue. And this is an important implication of the TNM staging. So to summarize depth of invasion in the 8th edition, for every 5 millimeter increase in depth of invasion, it upstages the T stage. You have a stage migration of T1 to T2 and from T2 to T3. You have better survivals now for T1, T2 tumors. The preoperative estimation of depth of invasion, however, still remains a challenge. Clinical examination is very difficult, not validated. You have to use radiology along with clinical examination that can be with a CT scan or an MRI. The pathological TNM is actually where depth of invasion is an important factor to decide adjuvant treatment. And now in the last 3 years, the new T staging has been validated with disease outcome in multiple studies. So it seems like a robust TNM staging. We come to the second part of the change that happened in the TNN staging, and that was the extranodal extension, which is ENE. Lymph node metastasis, as we know, is an important predictor of disease outcomes. Presence of ENE decreases your survival. So we all know it's an important factor predicting survival. What the 8th edition did was it just added this ENE to make the staging system more robust. They realized that this is an important predictor, an important prognosticator. It should not be left out from the staging system. And as you can see, the N3 got split up into an N3A and N3B. The N3A is a node that's more than 6 centimeters without ENE, and an N3B is a node that's more than 6 centimeters with extranodal extension, and you have both clinical and pathological. Now, the evidence for this also came originally from data from the NCDB database, which was again validated on the same institutional data from the MSKCC Princess Margaret group. They again found good hazard discrimination in most of the stages, end stages, not all of the stages. And then it came into the 8th edition. They also defined clinical ENE as presence of skin involvement of soft tissue invasion with deep fixation, tethering to underlying muscles or adjacent structures, or clinical signs of nerve involvement as clinical extranodal extension. This is a little more simpler than clinical depth of invasion. It is easier for us to identify, though not still validated as to how many of these are actually extranodal extension or no. Pathological ENE, they further classified into minor or major. This is not in the TNM staging. This is only for data collection. Minor as less than 2 millimeters, major as more than 2 millimeters. If you look at the implications of ENE, preoperatively, basically, again, to prognosticate and probably help surgeon plan surgery if you know you have ENE. Postoperatively, it's mandatory to document ENE in the pathology report. And this is basically for addition of adjuvant chemoradiation for patients with extranodal extension. So extranodal extension didn't really cause too much of a flurry for us. We were always reporting extranodal extension even before TNM came. And that was because it had an implication on adjuvant chemoradiation, but it's now into the TNM staging. So it becomes mandatory to now report it. Now, it seems that the TNM staging is doing well and is being well validated, but you always have to look at a contrarian view. Some articles now coming looking at the prognostic performance of the TNM 8th staging, which don't say that, which say that it's not really very good. This is a retrospective validation of 297 patients just published December 2020, which looked at the entire stage. This is not just the T stage or the depth of invasion. It compared the 7th and 8th edition. They looked at it with regard to survival. And as you can see, there is not too much of a difference between the 7th edition and the 8th edition. They said that the 8th edition had better discrimination than the 7th, but it was unable to discriminate between stage 3 and 4A and stage 1 and 2. And there are few other articles that have also said that the 8th edition is not absolutely perfect. It's difficult to get a TNM staging that's perfect because there are so many other factors besides T, N, and M that determine survival. They also concluded that the validation of the 8th edition in a larger data set is still required. And I think that's work in progress, and we have to see how they do. But as of today, depth of invasion and ENE are the main changes in oral cavity cancers in the 8th edition. The CTNM, clinical TNM, is a clinical radiological. It's not just a clinical, it's not just based on clinical examination. The implications basically are largely on prognosis. 2 is that depth of invasion causes a lot of stage migration, causes a lot of upstaging of disease, and a larger percentages of our patients, because of this stage migration, are going to have increased use of adjuvant treatment and change of adjuvant treatment. Thank you very much. Any questions? I'm very happy to take them.
Thank you, Dr. Gauri. There are a few questions.
So, Dr. Rohit, we will take the question after the all four talks are over, but I would request you to give a concluding remark before I go to the last talk of the today's conclave.
So staging is critically more important as far as prognosis of the patient is concerned. And hello, am I audible?
Yeah, you are audible, but I think there's some disturbance from your side. Yeah, now it's clear. You can go ahead.
Hello. I think my audio is gone.
Yes, we can hear you.
Thank you, Dr. Gauri, for the nice presentation. You have elaborated a lot about the changes in the TNM staging. How is it going to affect our clinical practice time is going to tell us, but definitely with addition of chemoradiation and migration of the stage from stage 2 to stage 3 with the increased depth of invasion has made a difference as far as treatment decisions are concerned. Secondly, about the HPV positivity, because we do have two separate sets, HPV positive and HPV negative, where more of the surgeons are doing laser surgeries and the robotic surgeries are going on for base of tongue and tonsillar tumors, particularly for HPV positive tumors, where you have an excellent prognosis, where you can avoid radiation in these patients from early lesions. So I thank you, and we'll be taking questions in the end. So I'll forward to Dr. Nandwani.
Thank you.
Yeah, thank you. So we now move on to the last talk of the today's conclave, and after that we'll be having a very interesting panel discussion. But the last talk, for that talk, I would invite Dr. Bhavna Dave. She's a very dynamic lady. She is at present she's completed a post-graduation from Nair Hospital. Yeah, so she completed her post-graduation from Nair Hospital Dental College, Mumbai in 1988. And currently she is the Dean at KM Shah Dental College and Hospital, Vadodara, Gujarat. She is professor and head in the Department of Pediatric and Preventive Dentistry at the KMS DSCH and also a PhD guide. She has various publications to her credit, has co-authored around 6 textbooks, and has about 20 years of teaching experience for undergraduates and the postgraduates, along with the immense clinical experience gained over the years. For the talk, I would like to invite Dr. Hitesh Devan. He is a consultant oral maxillofacial surgeon, and he did his DNB in 2003. He has been a professor and PG guide at the Department of OMFS at the Nadiyad, Gujarat, and his key areas of interest are trauma, TMJ surgery, implants, benign pathology, SMF, etc. So without wasting much time, over to you, Dr. Hitesh Devan. And after this last talk, we'll be now taking the questions also. But first, Dr. Hitesh Devan, over to you.
Thank you, ma'am. Is my audio clear?
Yes, audible.
Okay. Thank you, Dr. Somesh, to allow me for presentation, and I'm very happy to be in this august company. Now, SMF, I am as a maxillofacial surgeon per se don't treat oral cancers. I refer them to the oncosurgeons, but I have a huge number of patients with SMF coming at different stages. As you all know that Gujarat, India is the cancer capital of the world, and Gujarat is the cancer capital of India. So in Gujarat, we say that jokingly that the milk shops open little late, but the pan shops open early in the morning. So the extent of tobacco and its adjuvants like betel nut is so prevalent that patients, they come to us with basic problems of inability to eat, burning sensation, and difficulty to eat spicy food. And the most, and when we counsel them to stop the habit, when they come for a follow-up, their most concerned part is that their mouth was opening reasonably well when they were chewing tobacco. And once they have stopped chewing tobacco or supari, then their mouth opening has reduced. Because that is implemented to the fact that now the musculature is not into continuous use. So putting that fear of malignancy into them and counseling them and treating the submucous fibrosis is one of our mainstays of practice. So looking at this picture, when a patient like this comes to us, he is a living nightmare for us. What exactly you do with such a patient, right? We can't examine him. We don't know whether there is any lesion underlying inside, whether to counsel him for surgery. Even these patients, they push the tobacco and betel nut from the sides of the mouth with a pencil or with any other instrument also to get that kick because of that, of the habit, and they are not able to leave the habit. So, and the basic problem, as I told you, they come with burning sensation and inability to eat. And treatments have been varying in the past regarding the medical line of management and the surgical line of management. Briefly, as you all know, regarding submucous fibrosis, it is classically defined by Pinberg and Sissat, where it is juxtaepithelial inflammatory reactions and stiffness of the oral mucosa. These are the clinical presentations where we see fibrous bands all over the oral cavity, anteroperoral fosses, soft palate, buccal mucosa, even in the angle of the mouth and in the floor of the mouth also. The wonderful article which shows the basic transformation of the supple oral mucosa into a fibrous mucosa, where the 4 schools of theory are there, from the alkaloids to the flavonoids, the copper theory, and the constant chewing. Everything, as you all know, that the collagen, the basic type of collagen in the oral mucosa is type 3, and slowly it is converted into a type 1 type of collagen. And because of increased muscular overcontracture and increased level of soluble copper in saliva because of the arecanut and the alkaloids. And this is a flow chart which gives us the justification how the fibrosis develops and increases slowly and slowly. Now we must all be very clear what is the difference between the basic submucous fibrosis and radiation fibrosis. Now, when patients come to us with post-radiation, and if they have a pre-existing SMF, then the amount of fibrosis is much more as compared to patients with conventional submucous fibrosis. And it involves the joints also, and there's too many adhesions in the temporomandibular joint, and we need to not only go for intraoral fibrotomy, but sometimes we need to address the joint as well to release the fibrosis. And post-radiations, of course, we are bound by the chances of radiation necrosis. So we normally don't advocate too much of surgical intervention unless we find a potentially malignant lesion developing again, or a dental injury causing trauma to the underlying flap. Clinical presentation is fine, but the chances of malignant transformation in advanced submucous fibrosis is around 7 to 30%. And molecular markers and loss of heterozygosity is there. But I will not go into too much of theory. I'll just highlight a couple of cases and what difficulties, technical difficulties we face when we are treating the cases of submucous fibrosis. Very pioneering classification given by our peers, Khanna and Andrade, group 1, group 2, where the lesion is advancing, mouth opening is reducing to 26 to 35, group 3, 15 to 25 millimeters, and group 4 is the advanced changes. And histologically, there are hyalinized food sheet collagens, extensive fibrosis, obliterated blood vessels, and eliminated melanocytes and loss of epithelial retipex. But on top of that, when there is chronic or constant frictional irritation because of the dentition, there is a time where the malignant changes, they start. And unfortunately, it is very difficult to see because of the profound trismus. The therapy of submucous fibrosis has been varied. We are bombarded by medical reps who come with photographs saying that you prescribe our medicines, you will get wonderful results for oral therapy, beta carotene, steroids, interferons. All sorts of things are hammered down us. But honestly, this is not a treatable disease medically. Only if you are very, very clear in counseling them at a very early stage, then these patients do respond. But the changes of the oral mucosa sometimes, and more often than not, are permanent, and the fibrosis normally doesn't resolve. Surgically, we have been trying out a lot of things in the past, like just doing a fibrotomy, putting a collagen membrane. But our mainstay of therapy in our practice ranges from the buccal fat pad graft and the nasolabial flaps. These are the two sorts of therapy what we are doing. I am not trained in microvascular anastomosis or any other advanced procedures, but I will be just sharing some viewpoints regarding the buccal fat pad and the nasolabial flaps in my talk. Now, as I told you, the chances of regression of the submucous fibrosis is not there. And treatment is, of course, final treatment is your surgical part, but we have to identify these candidates, right? Other than that, what happens in our scenario, that our routine practices like any dental procedures are practically impossible. And if you have patients has a loose prosthesis in the mouth, the chances of developing malignancies because of the traumatic injury is much higher. You cannot even retract the tissues or any buccal retraction to see what is going on. And any treatment required in the posterior teeth is practically not possible. Simple extractions of the teeth, they become so and so difficult. Bleeding is profuse and suturing practically is not possible in these cases. You, more often than not, you will find a malignant lesion or a doubtful lesion in the RMT regions where the third molars are erupting. Those are the areas which have the most potential for developing the malignancies. So, when do you ultimately treat a patient for submucous fibrosis for the surgical intervention? My thought process is very, very clear. First of all, the patient should have mouth opening less than 15-20 millimeters. If he is able to chew normally more than 20 millimeters, we discourage the patient to go for surgical intervention because it induces more amount of fibrosis. Secondly, the timing of surgery means patient should have left the habit at least 6 months back before we enter into the surgical therapy. Why is that important? Suppose patient says, okay, now I will stop the habit, you just do the surgery. The problem is that first of all, his body is used to the tobacco, his body is used to the areca nut, and we are stopping that. On top of that, we are adding the trauma of surgery. And this not only creates a very vicious cycle that ultimately patients end up into a psychological problem and they restart the habit again. So patients who are really motivated to stop the habit at least 6 months prior to the release of submucous fibrosis, these are the real candidates who should be planned for surgery. And of course, who will agree for a very vigorous follow-up and very stringent post-operative physiotherapy. So finding a right candidate for surgery is a very, very challenging task, motivating them. Patients do get motivated because of the pressure of their family members, but then ultimately they have to be the people who will have to undergo the post-op physiotherapy. Again, during anesthesia also, you cannot do any sort of awake intubation. You have to have access to fiber optic intubation, even for doing simple procedures, for doing removing third molars, or we have to have a person competent enough who will give us the fiber optic intubations. So any extraction procedures, as I told you, it becomes very, very difficult. And we normally tell the patients to get your third molars out and at least the chances of the development of lesions in the RMT region becomes less, because that is the area where your chances of the malignancy is highest. When we do the surgical release of the SMF, one debatable aspect is whether to remove the coronoid process or just to cut and let it go. Honestly, we as aggressive surgeons initially, we believe that removing the coronoid is a big achievement, but honestly, it induces much more amount of trauma. And cutting the coronoid and just letting it go, that is the coronoidotomy, is less traumatic and it effectively gives the same type of results. Right? These are the two commonest flaps what we are doing at our practices. One is the nasolabial and is the buccal fat pad for release of the submucous fibrosis. Now, when we compare these two, there are 2 to 3 areas of concern. One very important concerned area is a young patient who does not want any scar on the face. Second criteria for inclusion of these patients is whether how much amount of buccal mucosa is fibrosed. You know, sometimes only the retromolar area is fibrosed, the buccal mucosa is free. So these are not candidates where you require interpositional graft. Right? Only removal of their third molars and doing the coronoid will take care of releasing the fibrosis. Patients who are of the older age group and have got excess skin in the nasolabial fold are actually the right candidates. But honestly, the buccal fat pad, although it is easier to harvest and it does not offer a second side morbidity, the problem with that is that it gets fibrosed over a period of time as it comprises of a similar tissue. Whereas the skin of the face, this nasolabial area, it does not get fibrosed and offers a long-term solution for treating the submucous fibrosis. The scars eventually they fade out, and patients they can definitely go for a good amount of physiotherapy in the later stages. A lot of articles have been highlighted in the literature, some giving advantages to the nasolabial, some giving advantage to the buccal fat pad. But buccal fat pad, over a period of time, what we have seen in many years, they do have a tendency to get fibrosed. And nasolabial offers a much longer and a more predictable outcome. The nasolabial also sometimes does not have, it has its fair share of mishaps also, like flap necrosis, and patients always complain of intraoral hair growth, which is many times cumbersome. Facial scars, of course, nobody wants on the face, but then it fades out over a period of time. The persistent orocutaneous fistula can be taken care in the second surgical intervention. Sometimes even you have the widening of the oral commission. Now, important is that if you injure this angle of the mouth during your fibrosis release, the patient, this area normally is not reconstructed because the flap, the nasolabial flap does not extend exactly at the angle of the mouth. And this raw area is actually quite painful to the patient, and patient gets demotivated to do the post-operative physiotherapy. And once that demotivation sets in, the fibrosis again sets in. So we have to be very careful not to injure the angle of the mouth during the surgical release. Another overzealous surgery done by somebody else, you can clearly see that if you injure the angle of the mouth, you can lead to adhesions over that area, and which may warrant another type of surgery and release. But again, these patients who have a tendency to develop hypertrophic scar, they can easily go into the refibrosis. Intraoral hair growth is one issue which patients do complain of, but honestly, over a long period of time, 2 to 3 years, it atrophies. And initial first 4 to 6 months, we can even go for plucking it out with the mosquito forceps, or a laser therapy is done after 6 to 8 months, at least once we are sure that the flap has taken up completely. Now, most important is your post-operative physiotherapy. And when we take these patients for the surgery, we have to really drill the patients for, because initially they say, yes, we will do the physiotherapy, we will do a lot of exercises. But once the pain part starts in the post-operative phase, they lose the motivation. Right? So that counseling of the patients prior to surgery is of extreme importance. After everything is done and every part is taken care of, patients always want some prosthetic rehabilitation, or patients have loose teeth, or they don't have teeth in the oral cavity. And this actually is very detrimental to the patient who want to do a proper physiotherapy, because these patients, they require good sound teeth on which their physiotherapy can be done later on for the putting of the mouth probes or using the Easter's Doppler or the Ferguson's Doppler. If the teeth are not there or if the dentition is very poor, the patients again lose the motivation for doing the physiotherapy and eventually leads to refibrosis. Very important part is during surgery that all the dental cusps which can cause potential frictional keratosis to the buccal mucosa, they should either be rounded off or at least if the third molars are there, they should be removed during the surgery. No cases we would like to deal with where we leave the third molars in situ, because again and again this is going to come back and the fibrosis is going to increase over a period of time. Couple of cases which have been treated. This was done by us and highly motivated guy. This was done with a buccal fat pad and a good amount of mouth opening was achieved. And females normally, you can see the injury to the angle of the mouth here, but she was quite motivated to get into the physiotherapy mode. And obviously being a female, she did not want any scar on the face. A female lady who has excess skin over and loose nasolabial area, these are good candidates for your nasolabial flaps, and they offer good laxity of that area. So you can easily insert the nasolabial flaps. The same case which I showed before, this is a 1-year follow-up of the same patient, and predictably these cases of nasolabial flap, they offer a much better solution as compared to your other techniques. And that's all. I just wanted to compare a couple of this thing between the two techniques, and eventually after many years of practice, we do have come up to the fact that first of all, identification of the patient with a good candidate for surgery. Secondly, motivating them for your post-op physiotherapy. And the third one is having a very long-term follow-up for these patients. Thank you very much for your kind attention.
Thank you, Dr. Devan. And we now move on to the concluding remarks from Dr. Bhavna Dave.
Hello, am I audible?
Yes, you
are. First of all, let me congratulate ICanCaRe team. It was a wonderful initiative to have this kind of programs, and to have this kind of program is going to really help us out. And as Dr. Devan has rightly said, that Gujarat being a capital of oral pre-malignant and malignant lesions, I would definitely congratulate Gujarat University too. Dr. Devan has explained everything so simply and very nicely. And I must say here that being a pediatric dentist, we have come across few patients who were, above 9 to 13 years. They've also shown us certain, areas where we can see those rural areas where we have seen the cases of submucous fibrosis. So what he's saying is absolutely correct. And we need to, curb this, what you can say, this kind of situation in Gujarat. Thank you, Dr. Devan, and thank you, the team.
Thank you, ma'am. Thank you.
So we now invite the questions, and I would start first with Dr. Devan only.
Yes,
there's a question from Aman Raj. How can we clinically distinguish the radiation and the OSMF, and does the treatment remain the same?
Good question, madam. Normally, history of radiation is something what the patient is going to tell us, right? Whether he has undergone radiation therapy or not. Now, when we are dealing with patients want a treatment of trismus post-radiation, we tell the patient that you have to be oncologically free for at least 3 to 5 years before we attempt surgical release of this fibrosis. We do not advise the patients to undergo a surgical release of post-radiation fibrosis at least for 3 to 4 years. And differentiation clinically is that the fibrosis in radiation is much more severe, and entire oral cavity, and sometimes if you see the CTs and MRI of the joints also, then the joints also, there is a lot of adhesion within the temperament of the joints. and we need to address those even externally. And but very, very clear aspect is that I don't advise the patients to go for surgical release. At least they are 100% oncological.
My next question is to Dr. Gauri. What is the actual tumor size in stage 3 cancers? Are you there, Dr. Gauri?
I think our audio is off.
Yes.
Okay, they were not allowing me to unmute. Now I'm unmuted. So that's a nice question. So the T size is only mentioned as above 4 centimeters. Anything above 4 centimeters, as far as T size is concerned, still remains as T3 and it stays as stage 3. If you're saying what is the upper limit of T size, nobody is given the upper limit of T size. What happens is if you have larger tumors, if you have a 4 centimeter, 5 centimeter, generally starts involving surrounding structures like bone, skin, and it becomes a T4 tumor. And that's why they've not given an upper limit to a T3 tumor. So anything that's more than 4 centimeters, just there is no upper limit given to a T3 tumor.
Ma'am, before you are muted again, I will first ask you only your relevant questions.
Sure.
So does the new TNM impacts the surgical plan or only the adjuvant plan and the prognostication?
So I would say it doesn't impact the surgical plan a lot. Except if you are, because the depth of invasion and the nodal extent, both are something that is more pathological. If you have thicker tumors, you are going to have, you're not going to look at the thicker tumors in millimeters. Pre-operatively, yes, you're going to look at the thickness of your tumor, but you're going to look more at what structures it involves. Like, let's say if you have a tongue tumor, yes, you want to know how thick a tumor is to plan your surgical excision, to plan your reconstruction. But really, you don't want to look at it in millimeters. You don't want to know if it's 3 millimeters, 5 millimeters, 10 millimeters. You just want to see what structures it involves. So really, surgical planning pre-operatively not so important. More important is for the adjuvant treatment and for prognostication that the new TNM system is in place. Yeah.
The depth of infiltration is being incorporated in all sites of cancers. You see esophagus, you take colon, you take stomach. The depth of infiltration is there except for oral cancers, where the depth was not there. People didn't know how to measure the depth and which structures to look into when depth is concerned. Now they have come out with the dimensions of 5 millimeters and 5 to 10 and more than 10. So that's how they are going to prognosticate patients. As far as treatment decisions are concerned, because we already know that these are the tumors, we are going for a selective neck dissection already in these patients. So with upfront neck dissections in plan, depth of infiltration doesn't hold much as far as treatment plan is concerned, pre-operative.
So I said the same thing, that it really doesn't matter with the treatment planning so much. It's more of prognostication and more for the adjuvant treatment. I agree with what you said.
So next question again to you, ma'am. Which are those subset of OPMD which are you would likely to observe and which you would likely to resect?
With regard to oral premalignant lesions, you have the high-risk ones and the low-risk ones, and I think that's been quite well defined. So for the high-risk ones, I would definitely like to operate. Even in the low-risk ones, I would definitely like to try. I would definitely do a biopsy for most of the low-risk ones also. With regard to high-risk ones, the ones that I will definitely operate are patients which have erythroplakia or erythroleukoplakia, verrucous hyperplasia, patients who have premalignant lesions on high-risk sites like tongue, floor of mouth, and hard palate. These are high-risk sites. So high-risk sites and high-risk lesions, if I feel there is a palpable induration, then that's again another very high-risk lesion and high-risk indication for surgery. Besides these, you will also, if the patient is very apprehensive, if the patient has no history of any tobacco usage, so that's one of the areas where you may consider resection. So if you have lady patients who have not used tobacco and you find that they have pre-malignant lesions, and this is one of the group of patients where you may consider resections rather than when you have tobacco usage as a significant factor. So high-risk sites and high-risk lesions are what will determine whether you want to operate pre-malignant lesions. Definitely every erythroleukoplakia I will operate, and most pre-malignant lesions on the tongue and floor mouth will undergo resections.
Ma'am, in today's scenario where we are not only just fighting against cancer but also COVID, there are some cases where there would be white adhesions on the gingiva due to COVID also. So how do we distinguish it clinically from the pre-malignant lesions?
So I did read that question. I must say I don't have any experience of too many patients coming to me with these white adhesions on the gingiva post-COVID. So my experience in this is not very high. So I'm not sure I've seen too many of these lesions. But I think it's important to understand that in differentiating pre-malignant lesions from this COVID lesions, you must have chronology. So if you had a COVID infection and then you developed these lesions, what you need to do is you need to give time to wait and look at what happens to these lesions rather than just running forward and taking a biopsy from these lesions. So you have to take a good history from these patients that these lesions were not present before these patients had COVID, and then these patients developed COVID and got these lesions. Then you probably know it's related to the COVID. Wait for some time. I assume that these lesions are lesions which will reverse, and then you come back and see the patient after 3 to 4 weeks. And if that is what it is, I must say I do not have much experience. So what is the time required for these COVID lesions to regress? I do not know. But you will see that most of them will regress, and then probably you don't need to take a biopsy. So I wouldn't think there's a hurry to take a biopsy if you have a good chronology and good history that these lesions came after the COVID diagnosis.
Dr. Nishit, what is your take on this question? Is Dr. Nishit with us?
Can I add one?
Sorry. I'm sorry. Yeah. Actually, I have not came across any white lesions on the gingiva, but the tongue, yeah, of course, I came across such lesions. But yeah, as Madam said, that normally the white lesion straight away should not go for biopsy even after COVID, because even as such, when I found any white lesions on the common locations with the patient with proper chronology, like long habit or something, then also I don't directly jump into the biopsy. Actually, we have to see the chronological factors and then we have to go for the biopsy. And most of the time, if you take biopsy of the white lesions from the gingiva, they don't show as such much. With of course, with proper chronology. And I don't think gingiva is a common site for the biopsy. Normally, the biopsies are taken from the red and white lesions at the margin only. So most of the times. So I think I would agree with Gauri Madam on that we should wait and watch. And one more, I'm sorry, but one more question about the candidiasis was there.
Yes.
So candidiasis should not be going for the biopsy, because whatever the lesions which are in the category of exclusions are the lesions which can be treated otherwise. Right. So once the lesions can be treated otherwise, like you can give any clotrimazole paint or maybe systemic antifungals. If it can be treated, then it should not go for biopsy. Why it should go for biopsy? Right. And as such, it is like, as far as being a dentist and being a general practitioner, it is sometimes like I'm not that much empathetic to the patient, but it is our duty to prevent unnecessary biopsy also. Right, whenever you can, yeah, it is if it is in your clinical knowledge and you can prevent unnecessary biopsy, of course. And whenever it is doubt, definitely it should go for biopsy.
So there are, thank you, Dr. Nishit. There's many questions, but I think these are questions more pertinent for the upcoming sessions on the next week, next Sundays. So I would not take the questions because of time constraints. Just two rapid questions I'll take before we go to the panel. The first is Dr. Nishit only. How do you counsel your patients for the Opmd which you found in the opportunistic screening process? How do you counsel them?
In the screening process, like whenever we found this, like I can say, almost every other patient who are having a history of habits, mostly they are having some or other lesions. Normally, what we do is we inform every patient about such kind of lesions, right? And like if you see the research, I would not point out my practice or maybe general practice, but if you see the research, I have came across a research in which out of in United States, almost 3% of the patient goes for the biopsy. And out of that 3%, 5% are being positive for oral squamous cell carcinoma. So that's a lot of difference. So, but yeah, of course, I would keep on trying to convince the patient for going for further screening, maybe biopsy or maybe stopping the habit or something like that, right? And sorry, yes, ma'am.
Yeah, yes, go ahead, go ahead.
Yeah, so that's what we do in our practice, and that's also I advise every other fellow to do in the practice. Just keep on trying, because this is the way we can, educate the people about the habits as well as for the outcomes.
Okay, I have lot of questions, but I think these will somewhere come in the panel only. But last question to Nishit again, Dr. Nishit, what is your final take that? More or less, what is your preferable biopsy type and the site? That's the last question I'm taking.
This is Dr. Krishna Kumar. Can we discuss these questions in the panel? Because it will be a repetition.
Okay, fine. So that is wonderful. If I have my enthusiastic moderator to start the panel. Over to you. I would like the chairpersons of this panel to please join in. Dr. Vijay Mathur, Dr. Bhavna Dave, and Dr. Prashant Shah, and Dr. Purushottam Chavan. But I hand it over to Dr. Krishna Kumar, and it's my privilege to invite him. He is a professor, Department of Hedonic Surgery and Oncology, Amrita Institute of Medical Sciences, Kochi. Reputed journals. He's been assistant editor to the Journal of Hedonic Physician and Surgeon, associate editor to the Frontiers Journal, Otorrangio in Hedonic Surgery and Oral Surgery. Very important positions at various important associations, and more than 190 publications to reputed journals. And he's been very enthusiastic today for his panel. So over to you, straightforward.
Just a minute, Dr. Krishna, for everyone, because we had a lot of questions. So there is a community page which I have put. Everyone can just log in, just join the community page, and we will put all the question and answer there from the speakers, from the faculty. We'll take the answers and we'll put it there. So just for everyone, there is this, I'm putting it again for the benefit of everyone. Just join the community page, and you can do it right now. It will just take 30 seconds. Over to you, Dr. Krishna. Sorry for intervening.
No problems. Good afternoon, everyone. Can I share my screen now?
Yes, please. Yes, please.
Can we introduce the panelists? Yeah, it is there. Okay, sorry.
Yeah, so the panel, you have heard a lot about managing potentially malignant disorders of the oral cavity, but I'll be dealing on the practical tips and management aspects. There'll be a lot of repetitions, I guess. And today on the panel, we have Dr. Mitesh Patel, who is a maxillofacial surgeon, Pawan Sinha Shah, maxillofacial surgeon again, Ashok Das is a surgical oncologist, and Reena Kumar, a dental surgeon, Dr. Akshat Malik, another surgical oncologist, Dr. Rashmi Shukla, radiation oncologist, Manmohan Agarwal, a surgical oncologist, and a pathologist, Dr. Riti Agarwal, and one more radiation oncologist, Dr. Hardik Patel. Are they all here?
Yeah.
Yes. Just yeah. So this is my first case. We'll be going through a series of simple cases which we all come across in our clinic. So this is a leukoplakia, very clear. It's defined as a white patch or a plaque on the oral mucosa that cannot be removed by scraping and cannot be classified clinically or microscopically as another disease entity. My question to all the surgeons here, Dr. Mitesh, when will you consider biopsy in such lesions, and what type of biopsy you will do? Dr.
Hello.
Mitesh? Dr.
Yes,
Mitesh?
am I audible?
Yes, you are.
Sir, when I find the history of the long-term lesion having a history of a long-term duration, just size is more than 1 centimeter, is I feel some nodularity in their thickened or speckle lesion is there, then I will prefer the biopsy.
Okay, so nodularity and speckleness and duration are the things which you consider. Dr. Pavan, what are your considerations? When will you think of a biopsy, or will you just observe? Pavan, are you here? Pavan Singhal?
Yeah, Pavan Singhal, yeah. So it is like it's a variegated appearance, or just he told us about the nodulity and all. It might be erythroleucoplakia, then I'll certainly go for a biopsy down there. And it is more than 2 centimeters for me. In my like practice, I prefer taking a biopsy in a lesion which is more than 2 centimeters, which is there for more than 3 months altogether. And then there are some changes patient has observed, or I have observed on routine follow-ups of the patient, like change in color or change in the texture, nodulity or spread of lesion, all those things, I'll go for a biopsy.
Some of them you may observe also. That's what you're trying to say. So when do you observe? Like a homogeneous lesions or something?
So I observe less than 2 centimeter lesions, which are homogeneous, which are flat, usually flat, and which are white, not speckled sort of thing.
Right. Dr. Gunjan Shah, what sort of biopsy will you do? Will you prefer to do an excision, a punch, an incision? What do you do? Dr. Gunjan Shah is here? He's not here. Ashok, Ashok, are you here? Hello? Dr. Gunjan Shah. Yeah, Ashok. My question was, you saw the lesion. It's a pretty homogeneous lesion. When will you consider biopsy in such lesions, and what sort of biopsy?
Yes, okay. Actually, this, as you have shown it very clearly, it's a homogeneous lesion. So first, I would like to go for some counseling and all. I am not very keen to do a biopsy unless and until I found some indurated area over that whole lesion. And if at all I found any induration kind of thing, then I will go for an incisional biopsy, because it's
The induration is one thing.
Yes, yes.
So induration is one.
If I found any indurated area, then I'll go for.
Okay. Dr. Akshat, are you here? What is your policy?
Yes, sir. So regarding the biopsy, I'll prefer doing an incisional biopsy.
Incisional biopsy. And what do you use some like staining, like AIDS, the Lugol side in all those things? Will you do you prefer?
I have used NBI previously, but then
NBI, for the audience sake, NBI is narrow band imaging.
Narrow band imaging, yes, that's right.
Yeah.
Along with that, but currently in my practice, I am just using naked eye examination, and I go as per my clinical acumen at present.
Right.
I would also mention that. Yeah. So these heterogeneous lesions, they can be also associated with some tooth trauma and all. I would prefer waiting for some time before going ahead with biopsy if I can see the inciting factor out there.
Right. Do you? So I'll show you this lesion. Okay. Dr. Mitesh again. What is your change in policy when you come to this lesion? Mitesh, are you here?
Yeah, yes, sir. This is a very widespread lesion. So definitely, sir, we are not excised completely, but we can take a biopsy.
Will you take a biopsy?
Yeah, it's a more representable area. We'll take the incisional biopsy first.
Which will be the more representative areas? From this diagram, here, you can see some red, whitish areas, thickened areas. You can see some red areas.
Sir,
so which area will you prefer?
Sir, I like to take a biopsy from the right and white mixed area is there. It's a more represented. I took another biopsy for the most thickened area of the lesion.
Okay.
And
so you take a multiple biopsy. In such lesions,
Yeah.
you take multiple biopsy. That's the point
Yeah.
you take.
Yeah.
If it is
Yes,
a
sir.
heterogeneous lesion, you go for a multiple biopsy.
Yes.
Akshat, anything to add? Do you risk stratify such lesions?
Definitely. So that is part of the history taking as well. We need to know about their addiction status and how long they have had the lesion for. That thing apart.
How do you risk stratify? Leukoplakia, leukoerythroplakias. Gauri, Dr. Gauri was hinting to, she told something about
definitely. It. So first of all, whether it is heterogeneous, the site of the leukoplakia, whether it is tongue, floor of mouth, and RMT, they are the high risk sites. So I would of course be wary about such lesions. Besides that, if it is heterogeneous or there is some induration involved, or it's erythroleukoplakic, or if the patient is a non-addict, then also I will be eager to take a biopsy or at least have my suspicion higher.
Okay, so the key point is that we have to risk stratify. We have to try to distinguish between high risk lesion and am I audible? Low risk lesions, and low risk lesions maybe we can wait a little bit, but high risk lesions will demand biopsy and appropriate management. So we have Dr. Riti Agarwal, our pathologist. What biopsy do you prefer, an incision biopsy or a punch biopsy? If you are to give some suggestions to surgeons, what will you say to them? How do you want the surgeon to do a biopsy? Dr. Riti Agarwal.
Yes, sir. Am I audible, sir?
Yes, you are.
Yes, sir. Sir, as a pathologist, if I discuss this case, like it's a heterogeneous lesion, so I would prefer multiple biopsies. And the two important things that we look for is depth and in situ change or dysplastic change. And the second thing, which I already mentioned in my lecture, also in my talk, that we need to see the relationship of the adjacent normal mucosa with the lesional change that is happening there. So many times what happens is, if it is a varicose or a, a keratotic plaque or anything like that, if the surgeon takes only the punch, so what I see in my pathology is just the hyperplastic, hyperkeratotic lesion is there, and which in case we embed it very flat because there's no depth to it. So it's of no use in a way.
So that's, the point is very clear, You have made it. So you prefer a deep biopsy, and you prefer a normal tissue along with the biopsy.
Very much. And especially if the surgeon is having his own clinical acumen, because sometimes, they really tell us that it's a varicoid lesion. They are very sure about that. So in those cases, until and unless the surgeon has his own limitation of trismus or any other thing, we would like to have a biopsy, which in case, if not deep, at least with the adjacent normal mucosa.
Right. So I got your point. So to summarize what you said, you need a deep biopsy. You prefer an incisional biopsy rather than punch biopsy, because punch biopsy can be the center of the lesions, and better include some normal tissue.
Definitely.
And if possible, get multiple biopsies if the lesions are heterogeneous.
Definitely.
Those are very good points. Now, my additional question: what do you look in this specimen specifically? And what are your challenges?
Specifically, whenever we get a biopsy, see, the size doesn't really matter at times. If I can really make out that I can see some base is there to the biopsy. So from the very start, the grossing happens and the bending happens. We make it sure that we have the proper plane to the section. We make it sure that we do not embed it flat. We embed it in a vertical plane so that I know that I can see the mucosa, I can see the deeper tissue, and so the alignment is there. And that is what. And in case the clinician is very sure it is not the pseudoepitheliomatous, though you cannot see any deep change or anything, we go for serial deep cuts, and we take the help of immunohistochemistry, CK also. A simple cytokeratin at times is so helpful, especially in inflammatory lesions, where you're not sure that single cell infiltration is there or not. So in those cases, the CK really highlights the spastic cells, which were, we were missing out because of the inflammatory background.
Dr. Gunjan Shah, as a surgeon, what do you expect from the pathologist report? The most important point.
Dr. Gunjan has not joined.
Dr. Gunjan Shah is not. Mithali, I'm sorry, I missed you. Dr. Mithali Dandekar, is she here?
Yes, yes, very much.
Okay, Dr. Mithali. So here's a question. As a surgeon, what do you want to hear from the pathologist?
So as I've been listening to this panel, two important things is predominantly all these oral pre-malignant lesions are clinical as far as the clinical judgment of the clinician goes. And secondly, yes, if you go ahead with an incision biopsy, as you correctly discussed, I would be looking for the amount or the measure of the dysplasia. Predominantly dysplasia. Whether it is severe dysplasia or carcinoma in situ. And it probably help me to make a better judgment call as to whether I should go ahead with a complete resection, or if the patient is apprehensive, I can still give him an option of very close follow-up.
Okay, so that's what I wanted to hear from you, the word dysplasia. So Dr. Rithi again, so how do you comment on this dysplasia aspect? There is some confusion or your binary system and
yes,
triple
sir.
system. What is that? What is it? How
Sir,
do you...
actually earlier we not earlier also still there's two schools of thought in which one is mild, moderate and severe, which really follows like how much loss of polarity has happened as we move from the towards the superficial layers. And then now what is...
So what is this binary system?
So now it's like low grade and high grade, where in high grade they have clubbed moderate and severe.
Right. Yeah, and again, Dr. Mitesha, how will this grading of dysplasia help you in your management?
So definitely we are, if a low grade and is a mild or moderate, so we can closely observe the, hello?
Yeah, I'm hearing.
It is a low grade or as a mild, moderate dysplasia, so we can observe and a close follow-up. Again, it's a severe dysplasia, so we like to excise
it fully. Okay.
Yes.
Right. If the mild dysplasia you may observe. Okay. I have two radiation oncologists, Dr. Roshni Shukla and Dr. Hardik Patel. I'll show you this lesion. Is there any role for radiation therapy in such cases? The surgeons were saying they're going to excise, but how much they will do excision? They just are going to come back. So is there any role for radiation therapy in this case? Dr. Roshni Shukla? Is she here? Dr. Shukla, is she here? Or Hardik Patel? I don't think they are here. Hello?
Dr. Hardik, are you there? No, both of them are not there.
Okay. All right. So this is a difficult lesion to treat. So Dr. Pawan, how are you going to excise this whole mouth?
No doubt, it is very difficult to do that.
Yeah.
Maybe I'll be doing it in piecemeals.
Right.
And because I can't take all block dissection for a dissection of this lesion as such. But you asked about radiations, oncologist's opinion. I think in such lesion it can upstage the tumor in these lesions. But of course,
radiation therapy is usually not advised.
Yes, it is not advised. So no doubt this lesion, if it turns out to be moderate to severe dysplasia or maybe a carcinoma in situ, I will have to take it out.
Right. And it is difficult in such a situation.
Although it is difficult to do this, I will have to take a residual margin also.
Yeah. Okay, can I make a comment?
Yes, Ashok, come on. You have a better way of taking this out? Ashok? Hello, Ashok?
Yeah, can you hear me?
Yes.
Okay, thing is that suppose in this particular patients, as patient is having a good mouth opening and there is a huge areas of involvement. So even I don't mind to take an opinion from the radiation oncologist. Because just excising
no, the problem here is
these
are the pick out.
Sorry, yes.
Yeah, I understand your point. But the problem is, many areas will be just dysplasia. They are not truly malignant. So radiation therapy won't work. We are, it's a difficult situation. We all agree. Let's move on.
May I just interject for a minute?
Yes, please. Akshat?
In the previous picture which we were showing, I would not go ahead with the excision of the complete thing. I would, like we discussed previously, we'll be taking multiple biopsies.
Yeah.
And I would take out the most unhealthy part, or depending on the dysplasia report, only that particular area with few millimeter margins. I understand that the entire mucosa is having changes, but then we cannot keep running after that. And that's a common thing which we find in our practice.
Let's all agree that it's a difficult lesion, and sometimes we do get such difficult lesions. So we have a dental surgeon here, Dr. Reena Kumar. How do you manage a leukoplakia in a dental clinic? Is there a situation when you decide that you will refer the patient to a higher center, then do a biopsy and then refer?
Thank you,
and
Dr. Krishna Kumar.
Yeah.
Thank you, Dr. Krishna Kumar, for the question. And I'm pleased to be here on the panel.
Yeah.
So where oral cancer is concerned and where a dental clinic is concerned, I think the role there is huge, because we really need to understand that a patient visits a dental clinic, and that's often considered the first point of care and the first point of contact.
Correct.
So early detection would be very important, and to reduce the mortality rate of these patients suffering from oral cancer. That's why I guess there's got to be a large amount of demand. I think we all have to draw in for non-invasive, rapid and easy to use techniques for early detection. And I think where this is concerned now, there are two aspects to it. One is, of course, educating our patient, and the other is educating our clinicians. That even it doesn't matter what the patient comes to you for, whether it is an orthodontic treatment or whether it is a XYZ implant treatment, but you are mandated to look inside the mouth and actually do a visual examination. So that is a mandatory thing. And at the same time, take a very intense history. One is, of course, about where is the patient coming from, because if the patient is located in certain parts of the country, and especially in the Northeast or wherever, where we have a lot of male population, over that the female is overriding that. The female population which is coming up with oral cancers is higher in these areas and in the central India. So in such a situation, we would like to understand what are the factors. So how much is the patient consuming tobacco, the betel nut quid, alcohol, smoking, what are the risk factors happening, and how much is it all this contributing to what is happening in the mouth? So that's important. And of course, a visual examination. You're saying something, Dr. Krishna Kumar?
Go ahead.
Okay. So what I would do, or I would teach my student to do, would be probably to do a visual examination, try to see whether this lesion can be a white lesion which can be wiped off or not. Can it be scraped off? Can it be not scraped off? So make one decision over there. And from there on, probably the better thing would be to call in and take an opinion, because it is very, very important. And if there is a habit, which is strong habit is there, along with that, you see submucous fibrosis, OSMF, and then along with that, there is leukoplakia, erythroplakia, and leukoerythroplakia is happening, and various plaque lesions happening. I think the need for looking at various, going into further screening, the screening would include, let's say, beyond physical examination, which would be, we would do a physical examination, which would be a systematic visual examination and palpation, lymph nodes, salivary glands, lips, inspect everything along. And along with that, probably a histopathological inspection. But most importantly, I think today's day, the role of the stains which have come in, as I think you were talking about that also, you asked somebody about it. So that was a really nice question, I thought. Really nice suggestion from your side. Because I think the visual staining technique, which we are all used to be doing at Toluidine blue, and now with things which have come up in the form of our stains, which are this, what are these things which we have these, I forget the name, the optical coherence, and then we have different kinds
imaging.
by which we
Visual imaging.
Yes,
So
yes, that's right.
Yeah.
Yes, I'm just forgetting the name.
One last question: is there a role? This we hear a lot about this breast self-examination.
Yes.
So, is there a role of mouth self-examination prevention and
absolutely? As I said, Dr. Krishna Kumar, that there are two roles to it. One is educating the patient, and the other is educating the doctor, the clinician. So where educating the patient concerned is one about good habits, of course, and the other is examining your mouth. And examining your mouth, and we have that chart, very clear chart, the 8-point check we have. So the patient is taught how to use the 8-point check, and of course the mouth opening, because that's the simplest thing that a person can do. How much is your mouth opening? Is your mouth opening 4 fingers, or having reduced mouth opening? And are you having any kind of lesions in the mouth? Do you have an associated habit? And what really is going on? So in that case, you are educating your patient to look at himself, empowering, and we at ICanCaRe have two things which we have, which is very interesting. I'm sorry, this is an ICanCaRe event, so I would really like to bring that up also, because we have a digital app, it's an ICanCaRe app, wherein the patient is empowered. Yes, we empower the patient, not just by education, but he can download this little thing on his mobile, and he can actually check to see whether his mouth opening is correct or not, and he can actually get educated by that. That's number one. And of course, these charts which are available, and so it is a clinician's duty to educate himself and to educate the patient and the families on both aspects. One is, of course, good, healthy health behavior. And the second most important thing I would say is self-examination and assessing yourself and coming in for a, you can really change the progression of the disease and what can be what can really be a issue, because we all understand that that if an oral mucosal examination can effectively reduce oral cancer rate by 40%, mortality by 40%. Okay. And the 5-year survival rate is very high. Those studies have shown that. Yes, Dr. Krishna.
So let me conclude by saying that dental clinics and the primary area of contact areas has a great role to play in preventing and diagnosing early cancers.
Good management there and good education there. Thank you so much.
Thank you. So to summarize this first part of the panel, homogeneous and heterogeneous leukoplakias can be there. Non-homogeneous can be speckled, nodular, or verrucous. The annual malignant transformation rate for all types of leukoplakia is around 1%. And we have risk stratification, and degree of dysplasia on biopsy is a major point on risk stratification. The other points like female gender, older patients, larger lesions, non-homogeneous, lateral ventral tongue, floor of the mouth lesions, and of course some biomarkers which we don't usually do. And the presence of dysplasia is a single most significant predictor of malignant transformation. And some visual staining and autofluorescence and narrowband imaging may do some help, especially in identifying the high-risk lesions and taking a biopsy. And we talked about the steps to prevent the recurrence of these lesions. So one last question in this point, Dr. Mithali, how would you look into this habit cessation and chemo prevention? How will you prevent these lesions? I'm coming back.
Okay, so to answer the second point first, as of today, we know there are studies which are ongoing, the curcumin trial, but really nothing that suggests level 1 evidence to prescribe chemopreventive drugs to all these patients. Yeah. And coming on to the first point, in fact, that is the single most important advice and counseling that one must give to these patients, because like we've been discussing for the last 20 minutes or so, these are very complex lesions. It just doesn't come as a single 2-centimeter lesion on the hard palate, which we go ahead and excise. There will be multiple field cancerization lesions in the mouth all over the oral cavity, and removing all of them is not an easy task. So habit cessation is, of course, of utmost importance. In fact, if it is a low-risk lesion, I would not really jump the panic button and go ahead and excise it. In fact, I would give the patient enough time, a window period, like we say, for cessation of habits, and then go ahead and prioritize the lesions and then decide further management.
Correct. All right. So chemoprevention is defined as an administration of agents to reverse a carcinogenesis, not very successful. Different agents like retinoids, beta-carotene, vitamin E, selenium, COX-2 inhibitors, and curcumin have been tried, but not of much use. Dr. Mitesh, do you have any experience on this curcumin? Anybody can answer that question? Curcumin. Dr. Pawan?
May I come in? May I come in, please?
Yes, please.
Curcumin has worked very well with our patients, and there's certain formulations, especially for a patient with oral submucous fibrosis, where we have Curin's gargle, which consists of curcumin, and based along with a few other products, really helps out and eases out. and helps along with the exercising, especially when we give them at-risk care and for mouth opening exercises. Along with that, it kind of loosens up the muscular tissue in there, and the collagen tissue kind of loosens up, and the patient is definitely better off. And curcumin has been tried by many dental researchers, and it has shown to have major improvements.
Yes.
And our product of one of the products, which is Turin's Gargle, I think by Pneumatis Sundumes. It's a very good product because we do give it to our patients, all the patients with oral submucous fibrosis, for gargle and rehabilitation during the mouth opening process.
Yeah, so
Thank
curcumin
you.
has some role. So this is a slide summarizing the lesion. We risk stratify. It is a low risk, high risk lesion excision. Low risk lesions, you can remove the irritant factors and follow up these lesions. And if they are progressing, we may have to consider excision. Now, some special situations, a small leukoplakia, okay, with some little bit reddish areas. Pawan, what do you do? Do you do an incision biopsy and an excision biopsy? And what margins will you take? Will you do some imaging before this?
I think this lesion, because it has got a reddish nodularity down there, I'll go for an excisional biopsy with taking around 2-3 mm margins all along.
And what if the biopsy comes as invasive squamous cell carcinoma? This is a common tricky situation. You know, you excise it close, and suddenly the report comes as invasive squamous cell carcinoma. So how do you?
I'll revise the lesion with supraomoid neck dissection at least, if it turns out to be invasive carcinoma.
Akshad, how do you do that?
So, in fact, I had one case in January, which was quite similar. Superficial lesion, and on excisional biopsy, it came out to be SEC with depth of invasion just 1 millimeter.
Yeah.
I went ahead.
So you excise the lesion, and if it is a thicker lesion, you may go for a staged neck dissection. Is that right?
Yeah. So even in this case, I revised my margins and I did a neck dissection. Okay. Like Dr. Pawan mentioned, we do take few millimeters margins, but then they do come down, and for CA purpose, we require more margins. We cannot leave it at that.
Right. Dr. Reena, okay, so we see this traumatic ulcers. So how do you differentiate between problematic lesion and the traumatic ulcers? Anybody can take this. Dr. Reena, I was asking you, here's a picture of traumatic ulcers. How do you differentiate and counsel your patient that it is not a problem? Can you hear me? I think she's not hearing me. Hello? Dr. Pawan?
Yes.
Hello?
Dr. Krishna, I'll at first convince the patient that it is not malignant sort of thing. It looks more like traumatic because it is flat. It doesn't have hyperepic margins. Yeah. So at first, I'll see to the inciting factor which has caused this lesion. So it might be the teeth, a sharp teeth. So I'll refer the case to dental surgeon. He will just polish the teeth and the job is done. But if it is not being corrected after that, within 2 weeks or 3 weeks, then of course I'll go and take it out.
It's a very critical part. May I come in, please?
Yes, please.
It's a very critical thing that these sharp teeth should be really managed, because these chronic trauma can again lead to something which is, we do know what it ends up with. So what really starts out as a small traumatic ulcer might have a long-term, not negative prognosis. As a result, they have to be identified, informed to the patient, and attended to by the dental clinic.
Right. So these are usually short-lasting. The causal traumatic event has to be clearly identified and dealt with. And these lesions don't have indurations, and they usually heal. And if not healing in 2 to 3 weeks, you should go for a biopsy. And two special situations like proliferative verrucous leukoplakia and chronic hyperplastic candida. Dr. Riti, how do you diagnose this? Riti is here. Dr. Riti, pathology. Hello.
I think network issue dropped off. I will connect with her and get her.
All right. Dr. Ashok, do you have some experience on these two lesions? Do you see them occasionally? Or any of the surgeons?
See them occasionally, and believe me, it's really a very tough situation. Right. The first one, this proliferative varicose leukoplakia. But again, coming to the basic, we look for any induration, mostly. We're back on that induration, that clinical findings. And if I got any suspicious induration, then I will definitely go for incisional biopsy and manage accordingly. And the second is, yes, it's in clinical diagnosis with a median this thing. So we take help of medications, and that's
Right.
all.
Right. Anybody, any difference of opinion here? Anybody gives antifungal therapy for this chronic hyperplastic candidiasis? Yes, Dr. Reena.
Yes, we do, because this hyperplastic candidiasis are often that, there is an issue of a fungal infection, overlying fungal infection. So we do give a long-term antifungal treatment is given. Yes, we do give it. But
Pawan, you were going to say.
Yeah, but these are nightmare cases, I'm telling you. Because these, when I palpate this tongue over the dorsum of chronic hyperplastic candidiasis, I am under suspicion, because most of these lesions are formed to hard. At some places, you will find formed to hard lesions. So at first, go for anti-fungal. If it is not getting anything relief, then I'll take a biopsy. Yeah,
Biopsy and excision, and these are lesions which have high chance of malignant transformations. So moving on from leukoplakia to lichen planus, the second lesions, very commonly we see, and not very difficult to diagnose on the tongue and on the buccal striated lesions, and sometimes we can also see the lichenoid lesions, lichen planus and lichenoid lesions. Okay, Dr. Mitesh, how do you explain this to the patients? Do you take a biopsy? How do you manage? How do you differentiate between lichen planus and lichenoid lesions? Dr. Mitesh? Dr. Gunjan is here now. Mithali again. Dr. Mithali?
Yeah. So first and foremost, am I audible?
Sorry. You're audible, Mithali. Yeah.
So first and foremost, like we've been reiterating over and over again, all these white lesions, red lesions in the mouth are a clinical judgment call. Anything that appears suspicious, which we have discussed at large, anything which is indurated, anything which is nodular, speckled, we will not wait and watch. Lichen planus, typically, like you've been showing in your pictures, they have these reticular whitish striae, and they are mainly symmetrical, mostly on either side, give typical history of waxing and waning with time. So I'll ask my patients to take it easy with them. Yes, they would have symptoms of burning sensations, and would like to observe them with medical management.
Akshat, how do you differentiate between this lichenoid lesion and the lichen planus? Akshat?
So it will, that depends on the biopsy only. Clinically, if there is some minimal induration, probably yes, but then it's very difficult to differentiate. I would still biopsy these lesions. In fact, in UK, where I was practicing earlier, there we had less number of oral cancer patients, but we had many patients with similar looking lesions who used to come up. And we had to biopsy it before saying that it's lichen planus or not.
Yeah, that's a good point. Dr. Reena, you want to
Yes, I want to add something, because you see a lichenoid reaction is we see a lot of it in the dental clinic, because most of it is actually a reaction to something which is the tissues have been in contact with. So this could be a metallic restoration, because Yes, there's always a factor. The cause-effect factor has to be really found, and it is easily found because you see there are patients who are wearing dentures, and many times if the dentures are not made in proper clinic, then you have this monomer which is still leaching out, and if it has not been heat cured and done properly, then what drugs are they using? It's very important to take that, and also the restorative, because the old-time fillings are all the silver amalgam, and is there something which is happening, a galvanic current, and what really is going on? So it's basically an antigen fixing of the epithelial cells. So I believe that a very good protocol of history has to be followed in here, and the lichenoid reactions can be recognized in a dental clinic pretty easily.
Right. So it's a complex chronic inflammatory disease that affects about 1 to 2% immune mediated. Malignant transformation of OLP is less than 1%. Reticular erosion dangerous, I guess, with a little more of malignant transformation. Lichenoid lesions usually have these associations like drugs, dental restorative materials, and this graft versus host disease. That's history has to be properly taken, as Dr. Reena was commenting, and clinically they are usually unilateral. You agree? Yeah, and lichen planus lesions are bilateral, and a little more of malignant.
I have seen a very interesting lichenoid lesion when a patient who had a gold restoration and a silver restoration. So you see there was a galvanic current set up inside the mouth, and there was a cell which had been formed. So as a result, on both sides, this patient had this very severe lichenoid because it was like a electrical cell which had been created in it with 2 electrodes, one silver and one gold, sitting in there, silver amalgam filling and a gold restoration. So it was quite a unique one, and it's been reported by us.
So always the point is always look for some factors which are responsible, like drugs history or like dental and amalgams, and then you can suspect lichenoid lesions. And otherwise, if it is a typical picture of lichen planus lesions, and mind you, both these can very rarely turn to be malignant. Now let's come to the last lesion for the day, submucous fibrosis. We heard about that in detail, but just to sum up some practical tips from you all clinicians. Dr. Mitesh, is he back? Dr. Gunjan Shah, is he here? How do you prevent? Yeah, please. How do you prevent these lesions in your clinic? Submucous fibrosis. Hello, prevent or progress.
Hello, sir.
Yes. My question is about a submucous fibrosis. How do you prevent the progression? Hello.
Mitesh, unmute yourself, please.
Hello.
Yeah, we can hear you, Mitesh. Go ahead. Mitesh, unmute.
Hello, sir.
Please go ahead. Yeah, go ahead.
Most of patients having submucous fibrosis having a history of betel nut chewing or tobacco chewing. So we have to first quit the habit, quit the habit, then just do the physiotherapy as much as possible. So this is the best way to prevent the submucous fibrosis.
May I come in, Dr. Krishna Kumar, please?
Yeah, very good.
Dr. Krishna Kumar, if you allow me.
Any role for some nutritional,
Yes, sir. Generally, patient asked to have a balanced diet, good balanced diet, and then we generally use the carotenoids and this medicine for a long term.
Yeah.
May I come in, Dr. Krishna Kumar, if you permit me?
Right. Dr. Reena.
Yeah, I don't know why. Can you hear me? Because it's showing that I'm muted. Okay.
So how do you prevent the progression?
Yeah. So
Dr. Reena,
I believe that the best thing is prevention. So prevention is, of course, a good habit, good counseling. Getting of that is number one. Number two is what we would do is mouth opening. So we have developed at ICanCaRe a beautiful, simple tool, which is called a TrisCare, which is the patient is given and he or she can place it in the mouth and open it. And there is a grading scale which tells as to how much is the mouth opening which has happened and how much does it open, and progressively do this. Along with that, there are gargles, as I said, And along with that, there are micronutrients which are given. So there are vitamin E, C, D, and these are given to the patient with lycopene. So, so all this put together really works for the patient. So, but the most important thing is to continue working on the mouth opening, and that is with an instrument called Triscare, which we have developed at ICanCaRe. It really works very well. And it's a very small, adaptable. A lot of instruments, of course, are available in the market, starting from simple gadgets of, little elastic modules, all the way down to this. So basically, it is about the habit stopping.
Great points. I would request you to put all these. I would request you to put all these, the gadgets you're telling, or the in the chat box, so that
Thank
the
you.
audience.
We do that. We do that. Thank you.
Right. And regarding the management, Mithali, this Placentrex extract, steroid injections, have they worked in your hands?
So a point one must understand about submucous fibrosis is it goes through gradings. It goes through 4 classical steps. The initial stage 1 and stage 2 are the early changes, wherein there is more of mucosal congestion. The fibroblasts are just setting in, and it is the advanced stage actually where the fibroblasts become more mature, the blood vessels actually undergo constriction. So these advanced stages are the ones which are more of a management challenge. And yes, there have been various agents, hyaluronic acid, Placentrex. Really, unfortunately, nothing has been shown to be foolproof, and that is the reason we have so many agents which come into.
So that's the point I wanted to make out. Many of these medical injection managements are not of long-term use. Dr. Ashok, any experience with Placentrex, hyaluronidase, or all those things? Ashok?
Yeah. Okay, sorry, I don't use these things, but I have seen quite few dental practitioners, dental surgeons they use, and they claim to have some good results.
You're a surgeon, but you don't believe in all this.
Yes, because basically those patients whom I see in my clinic, basically they come in the very late stage, and particularly the kind of patient you have shown in the picture. So unfortunately, I miss those early stage disease patient, and this patient who comes to me in an advanced stage, they really need surgical intervention.
Right. Pavan, how do you manage surgically these cases?
So I've tried coronodectomy. I've tried with the nasolabial flaps, even SSGs. Yeah. Then when I saw the presentation of Dr. Madan Kapre once during our FHNO, I started using that mandibular mucosal flap. And that is, I think that is very good after doing a laser mucosotomy in oral submucous fibrosis. Do with laser, make a Y with the laser, then in that space fill this mandibular mucosal flap. It works well. Nasolabial flap, I'm not using much because it gives a lot of cosmetic deformity there on the face. And the third thing, what we could do is, if it is too much grade 3, 4, and the patient is willing or the facility is available, like at your center, I'll go for bilateral or maybe unilateral radial forearm flap.
Right. So the essence is that if it is if submucous fibrosis is severe enough, you'll have to go for a surgical management. And of course, as the previous speaker told, there has to be a lot of motivation. He was using the word motivation again and again. There has to be motivation from the patient to undergo these exercises and so on. And in such patients, we have to do surgical management with the release and some sort of interposition graft. So the malignant transformation rate is about 7 to 13%. We have to counsel regarding cessation of habits, correct nutritional deficiency, mouth opening exercises, submucosal injections like hyaluronidase, collagenase, placental extract, not of much benefit, and surgical removal of fibrous tissue and use of tissue graft. And that brings us to the end of this panel. Thank you all for this excellent contributions. Any other last points from all of you? Any other last
Can I make a comment?
Yes, Pawan.
A small comment.
Yes.
For self-examination, Dr. Dina was talking about, what we do is I teach my patients to go ahead for 3-finger examination. You just put your 3 fingers
What is that?
in the mouth. See to it. Just put in your 3
What
fingers
is
like
that?
this. Like this, you
Yeah.
put in 3 fingers among your teeth. If it is openable to that extent, that means there is nothing like that. And if you advise them to see again and again inside the mouth, they might come with anxiety problems again. So I think it should be done with moderate guidance.
Exactly. You know, the forefinger mouth opening, as we say, that's a restricted opening in every patient. So, so that's one of the things what I talked about, and one of the early things that can be easily told because the patient has a restricted mouth opening. Dr. Krishna Kumar, if I may say something, you have been an excellent quiz master, and I think you took this panel discussion to a great height. And thank you so much. I really enjoyed being here. Thank you so very much.
Thank you. Dr. Mitesh Patel, any last point to add? I'll just request all the panelists for anything to add. Mitali, you have something to add?
If you can stop the screen share, it would be easy for we can give the space there. Yeah, thank you, sir.
Sure. Yeah, Mitali, continue.
Yeah, so oral potentially malignant are disorders and they're not just lesions. So take care of it in toto by giving a holistic counseling as far as habit cessation is concerned and cure of the irritant factor, mainly dental in origin.
Very good point. Very nice point. Ashok, your last point. Ashok Das. Akshat.
Yeah. So I guess
Anything
we
to
have
add?
already summarized quite well. I would also add on that all these patients, they have in spite of what you do, such lesions may come back and they might even progress. So patients need to be aware of that and they need to be cautious about it.
Okay. Dr. Reena, any last points?
What we would say is that that I would implore that every doctor has to be, every medical person, every person in every person's clinic has to be talking to the patient about habits, because prevention is the way to go. And unless we have well-educated and well-aware people managing our clinics and ourselves, I think we cannot manage our patients very well. And mouth opening is one of the simplest ways to check good habits, and talking to people and finding out what is it that, maybe Shruti, you're here. Would you like to show us the Triscare? I don't have it, other than I've shown it just now. Yes, I think this is one of the things that I was talking about. So this is a simple one that we have. So probably every clinic having one of these, equipping it with this, such that it's very simply that the patient just places it in the mouth, gauges how much is the mouth opening, and turns it around by himself or herself, and is able to open the mouth, and then keeps it and can be collapsed and taken. That's a reading which can be put in. So I would suggest that I think it's very important that we go the prevention way, and education, prevention, talking, not just for ourselves, our patients, but every person in the clinic, and be a 2AR, if not a 5A person.
Right. Mitesh, you have been missing for some time. Mitesh, is he back?
Thank you, Shruti. Thank you.
Mitesh, anything to add? And lastly, Dr. Riti Agarwal, our pathologist. What is advice to all these big surgeons? Riti Agarwal, your last point.
She has not been able to join, so she's not here actually. She couldn't join back.
Okay. And the radiation oncologists are also not here. So thank you very much. That was an excellent panel. Thank you. Thank you, ICanCaRe, Dr. Vikram, and all the organizers.
Let's all give a round of applause to Dr. Krishna Kumar. I think he's been fantastic.
Thank you. Thank you very much.
So I think that was a wonderful panel discussion. And before we say goodbye to everyone, I think we'll have a concluding remarks from Dr. Somesh Chandra. Over to you, sir.
Hello.
Yes, sir. You're audible.
Yeah, I thank all today's speakers and Dr. Krishna Kumar for an excellent conduct of the panel. And I think Shruti and you and everyone who's been busy getting people registered and sending out messages about the event, you've done a fantastic job. We had more than 200 people attending the sessions. And that in COVID times, I think, to have so many people together is a great achievement. It's like any large national meeting of a prestigious organization. And I'm sure that FHNO would appreciate that bringing different platforms together definitely works in the interest of everyone. And this has given us a very important message that if we bring the multiple disciplines together, how much more we can achieve and how much more meaningful and multidimensional we can make our meetings. Thank you.
Over to you, Shruti, for anything. Otherwise, we'll say goodbye.
I think it was a great discussion, excellent speakers and extraordinary learnings, I must say. And I hope our participants also enjoyed on all the forums. Mr. Sharisha, this is the Triscare, a wonderful, simple device, a mouth-opening device which has been designed for submucosal fibrosis management. Very simple to use as well because it has to be rotated, simply rotated from bottom, and then the pressure is elevated. So simply it can be rotated from the bottom, and the mouth opening works, and the protocols are very simple as well. And there is a scale here, so the reading also becomes very simple. So the link has been dropped on. I'll request everyone to please have a look at this device because I feel that this is going to be very, very beneficial for all the patients out there. Other than that, I hope that all the questions were answered and everyone enjoyed and loved being part of this session today. It's day one, and I'm sure the energy, the tempo is set. It's very high. And the upcoming sessions are again filled up with lot of energy and lot of dexterous topics and unmatched surgeons with unmatched potentials and dexterity coming us and addressing us. So stay tuned. If there are any questions, please feel free to drop us those questions on either the feedback link or on social media, and we will try to get the answers from the panelists for all your questions. If you have any comments or suggestions, please do write to us at info@icancare.in, and we will see you again next Sunday on day 2 of the E-Conclave at the same time, 4 p.m. with more topics, with more discussions, and more things to take away. I'll now invite Reena ma'am because she has something to say.
Dr. Pooja, you were just amazing. Thank you for holding this through, and you were just fantastic. Thank you for doing this for us and making it so wonderful.
No, it was excellent teamwork, and I think all the speakers and the panelists did a wonderful job. And I look forward for more involvement, especially being the radiation oncologist. I look for my involvement more in the clinical part. So see you next Sunday, sharp 4 p.m.
Yeah, thank you. And before we end, I would request, we have got still 123 people here. I'm just giving the link of our community page. Please, I would say that just join the community page so that we'll be connected. We will, the things that we have learned today will go on for long, and it can be, we can have it, we can reach out to more people through that. So this is the community page. It will just take 30 seconds. And I request every one of you, please do join the community page right away so that don't leave it for the later period. Let us do it right away so that I can see the community page and people are joining in. Thank you so much. A lot of people are still joining in. Yeah. So we have got 63 members who have joined in right now. And I thank you so much. And I will look forward for all others to join also, if you have not yet joined. So what we are going to do, we will put these questions on the community page so that you can come on, you can discuss this thing there. Then all the videos that we had today of the wonderful session, each video would be given the link there on the community page. So that way we can transmit or we can reach to more number of people even after the today's session is over. So today we had approximately 423 people on the Zoom. Of course, some of the people had dropped off, and we had a lot of people on the Facebook as well as on the live, on the YouTube live. Almost like on the Facebook, we had around 223, and on the live session on the YouTube live, we had 124 people. So that was a wonderful session. I think congratulations to the whole team, and thank you for the faculty, moderators, and the chairperson. And special thanks to our Dr. Anil D. Cruz, Dr. Pandya, Dr. Somesh Chandra, Dr. Alok, and of course, Dr. Harit Chaturvedi and the whole team who had worked together. Thank you so much. Have a great day. Bye-bye.
Bye, everyone. Have a great Sunday. We'll see you next Sunday at the same time, 4 p.m. Thank you.
Thank you. Bye-bye.